All right. Well, good morning, everybody. Thank you all. This is our first HHS committee session since March. And I want to begin by acknowledging the incredible work of the Department of Health and Human Services over the last 3 months. And thank you, Dr. Crowell, and you, Dr. Gales, for all that you guys are doing and your teams. I know this has been incredibly stressful on every conceivable level. And I think we're going to come out of this stronger. There are a number of lessons learned, but it's exciting to be able to get back together as a committee. And a point of privilege, and I want to make sure I get this right, so bear with me, but I want to acknowledge the Rice family, and in particular, I want to congratulate Anaya, class of 2020 from Northwest High School, who we learned yesterday was the nominee for the Rosette Award. So congratulations, Councilmember Rice and your beautiful family. I see the apple does not fall far from the tree, my friend. And just acknowledge both you and all of the students this year for everything that's going on. So congratulations to your family.
Thank you so much, Mr. Chair. Really, really appreciate it. It's a very proud moment for us. Had to disconnect myself from everything. So I apologize to you and others who are calling yesterday about very important information, but wanted to make sure, because so much has been snatched away from this class, certainly dedicating ourselves to having a moment to where nothing is distracting us from the attention that they deserve for all of the hard work that all of these students have put forth over the years. And so really is a great culmination for a lot of students all across the world, quite frankly, who have been disrupted by this pandemic, but certainly one in which we know is going to certainly bear fruit when it comes to their ability to navigate tough situations in their future. So thank you very much.
Absolutely. Absolutely. And with that, let's go ahead and get started. We have a packed agenda. Lots to get to this morning. We have 3 items we'll be discussing this morning, and then this afternoon we have a joint HHS and Education and Culture Committee meeting. The 3 items are: we will be discussing the Ngo Teams, or the county's response to highly impacted zip codes and group homes for the developmental disability community. Second, we will be discussing the developmental disability supplements, which we had talked about coming back to and revisiting during the budget process. And finally, we will discuss the food security issues during COVID-19. This is a follow-up to the full council session that we had earlier this week. But we'll start with the first item on the agenda, which is a discussion regarding the Ngo Teams. And joining us during this session will be Dr. Crowell, Director of HHS, Dr. Gales, Director of our Public Health Services Division, Dr. Odile Brunetto, Chief of DHHS, the Honorable Lord Charkoudian, delegate from District 20, Jane Park with Impact Silver Spring, Karen Cabral, also with Impact, and Valeria Salazar, also from Impact. And also joining us is Rick Callahan, the Executive Director of Compass Incorporated, Steve Kinnear, the Executive Director of Jubilee Association of Maryland, and Christy Shaver, the Chief Executive Officer of the ARC of Montgomery. So as we know from the beginning of the pandemic, there are certain at-risk communities that have been disproportionately impacted. And we have seen that within our long-term care facilities, in our group homes, and our nursing homes. And we've also seen it disproportionately within zip codes. And I really want to give a lot of credit. I have been chair of HHS for less than 2 years, but Councilmember Rice has been on the HHS committee for much longer. And I know this and the previous council have been very much focused on the disproportionality of health impacts in communities. And we have seen with absolutely tragic and catastrophic consequences how in this pandemic that has highlighted those differences even more. And again, to our public health office's credit in HHS, we have initiated strategies to address this issue, acknowledging that this has been extraordinarily challenging. First, it was accessing PPE, then it was accessing tests, and tests remain a challenge, although much better than we were before. And of course, the complicated aspects of having to coordinate this effort along with the state and trying to tackle a virus that we were not familiar with and trying to gain access to information all along the way. And then you add to the layer of the economic despair that communities are feeling, and you have the perfect negative storm. And so I know that we have put up efforts. There have been a number of lessons learned through this process, and we have a number of key community partners, such as those that are represented on our discussion today, that are going to be key now and moving forward to help solve this issue logistically. So with that, I will turn it over to Dr. Crowell and Dr. Gales to make some opening comments. And if you could provide some context for the structure of the Ngo teams, how they have worked thus far, and there's crossover between both the disability community as well as the strategy within the zip codes. But why don't we give a broad overview, and then in order of how it appears in the packet, we'll discuss the zip code approach more specifically first, and then we will follow that up by discussing our strategy within the developmental disability community. Okay. But with that, Ms. McMillan, was there anything you wanted to say in advance, or is there anything you want to make sure that we cover that I haven't stated outright yet?
No, I think you've covered it. Just that in the packet is a memo that the HHS committee sent that I know you'll go through those issues today, that did cover both concerns about the current and future efforts for the impacted zip codes and for the group homes for developmentally disabled persons.
Great. Thank you, Ms. Millen. So Dr. Crowell and Dr. Gales, I'll turn it over to you to make some opening comments.
Okay, thank you. I think with me, Dr. Gales is, along with Dr. Gales, is Dr. Odile Brunetto, who's our Chief for Aging and Disabilities, to talk with us, to join the conversation as we start talking about the developmentally disabled community and the group homes and providers that are operating in that space. Good morning, everyone. I think beyond a doubt, everyone is aware that we have had some, this has been a painful process for the entire county as we've gone through this pandemic, and as we come out the backside of it, there are some, we need to be very much aware that we are not free and in the clear by any stretch of the imagination. Looking around the country, I see folks who may have opened up prematurely and now seeing second waves, and we need to be very mindful of that, I think, as we go forward. I think it's painful on a number of fronts. What we've seen now in terms of the zip codes, in terms of the disparities that have occurred, that are showing up, and that are part of a fractured, that highlight the fractures in our community in terms of health disparities for a very long time, that have existed for a very long time, both in health and mental health and in the entire social safety network. All of that is been highlighted by this pandemic. And in the middle of that, trying to respond to something we've not seen in anybody's lifetime, we are creating solutions on the fly and have been for many, many weeks now, trying to create and solve problems on the fly, both in terms of the things you talked about, the PPE, getting protective equipment to people, figuring out how we stand up testing, how we link people to social services. All of that has been, the existing structures have been tested to the limit, and the new things have had to put in place to adapt to all of those. We had received a letter from you all, along with the correspondence from Impact and Delegate Charkoudian several weeks ago. We've been working on a written response when we saw this meeting coming up. So I thought we're going to hold that response a little bit and talk about some of those issues today, and then we'll get you a written response as soon as possible after today. I think I want to think about a couple of things. I want to ask Dr. Gales to talk a little bit about the Ngo teams and our experience with the Ngo teams, and the overall state response, and how we've wrestled with and dealt with the challenges that they've presented. The Ngo teams have been both a challenge and a necessary and useful support. So Dr. Gales will talk a little bit about that and where our response is now and what we think we'll do going forward. And I want to talk a little bit about the coordination and partnership that we've enjoyed, not only with Impact, but with a lot of partners around the county, and where I think that needs to go in next steps. One of the things we talked with Delegate Chargoutian and Jane Park from the Impact team a few weeks ago about the issues that appear in the letter that was forwarded over, and about the ideas about community partnership. And indeed, those ideas make a lot of sense and made sense to us before we got the letter, and make sense and continue to make sense now. We've talked a little bit, Councilmember Alvin knows, about the hub models, the consolidated hubs that are standing up. So I want to talk a little bit about how I see that happening and how I think the partnerships can play a role now and going forward in the future. So, and then of course we'll talk about the developmental disabilities community in turn. So let me start by turning it over to Dr. Gales to talk a little bit about our teams, the Ngo teams, and how we're dealing with that.
Good morning, everyone. Councilmember Alvarez, Councilmember Rice, and Councilmember Glass. Always a pleasure to be with you. And it has been a while since we've had an opportunity to meet and talk about health-related things outside of a larger group. I do want to provide some context in terms of how the Ngo teams came to be. And how they were intended to function, as well as provide some context in terms of some of the logistical issues that we experienced with the system overall and with individual partners. So the idea came from the State Department of Health. In particular, Dr. Howard Haft oversaw the program, and as part of the COVID response has been looking at opportunities to provide additional services for vulnerable populations across the state. He and I had a conversation. I can't remember the exact date. It was actually the first day that we launched our VEEP station testing site, where he called and we had a conversation to discuss how we can provide additional support for vulnerable populations across the state. And at that time, the Department of Health was coming up with a vulnerability index to look at risk factors for certain groups and certain populations as it related to COVID-19. Out of that larger discussion from myself and including health officers across the state, as well as other officials at the Department of Health, they created the concept of these Ngo teams. And the premise was that the Ngo teams would be able to go into, it would include some type of healthcare provider, whether it's an EMT or nurse or a practitioner, and pair them with social support services to be able to go into communities and provide testing and provide linkage to social support. And the state decision was that they would have 2 teams to go to the 4 jurisdictions that had the highest number of cases. That would be Prince George's County, Montgomery County, Baltimore County, and Baltimore City. Now, within that, each of the jurisdictions could utilize the teams however they liked. Now, when we first had those logistical conversations, we reached out naturally with our services to end and prevent homelessness within HHS as an opportunity to provide testing for our shelter community. And then there were multiple conversations with everyone from the county executive to Dr. Crowell to other folks within HHS, as well as Chief Equity Officer Ward, to identify other community partners. And I know there was outreach to a number of different community partners. The one that did reach back out and say, yes, we're interested, was Impact Silver Spring. And so that began a conversation to talk about how we could leverage those resources to connect families to testing. The intention from the very beginning was not that this would be teams dedicated solely to homelessness, dedicated solely to impact. It was teams that could be leveraged and moved around to meet the needs of the county. And even we talked about, I know with you, Councilmember Alvarez, potentially using some of these teams to provide testing for the D&D homes. As you know, as part of our larger response, in addition to the ready responders, we also created action teams and Ngo teams for our nursing homes at the end of April. At the end of March 30th. And we also created a model for our D&D teams, Ngo teams, and we have created something similar for our child care teams that we're hoping to roll out and sustain to get those facilities ready. So as a result of those conversations, we did reach out in fact, pushed the model out to try to get families tested as quickly as possible, particularly from the arm working with Impact. And that included the ready responders going into homes that were identified, that were provided to us, or not to us, but to the ready responder team to do testing. The model was that they would do the test, they would drop them off at the health department, we would ship them to the state lab in Baltimore, and they would be processed. Now, we did experience significant issues. Again, this was not only specific to Montgomery County, but also in Baltimore County in particular, with how those results were communicated. In fact, about a weekend, so I think if I'm looking at my notes correctly, the efforts were launched on April 24th. About a weekend, we weren't getting results and trying to understand that system. And so in early May, separate from any conversations with anyone who is a part of this call, there was a meeting convened by state officials, including Dr. Haft, other folks at the health department, representatives from us, representatives from Baltimore County, Baltimore City, to talk through those logistics. And the reality was there was a system that did not work in terms of how the labs were being submitted, in terms of the paperwork, who it was attached to in terms of a provider, as well as how that information was being communicated back to the local health departments. So the challenge we discovered was that tests were being done and we didn't have a mechanism to match the names coming in. We didn't know who they were. And so we had to go through and hunt that information down. And then that created a backlog. And so when that was identified, we on our end went through and tried to find those families. I think as we've discussed before, I called a significant number of families myself, giving out results. We discovered that even with that shift in things, there was still a bottleneck in terms of getting results. And so we had a separate conversation with the state to talk about how to make those adjustments and improvements. And we shared that information with the respective agencies. And we worked through that. There still continued to be a number of families who were not receiving results, particularly those individuals who were from the very early stages in that initial, so from the very beginning to early May. And what we did, the short-term strategy was to pull nursing staff from one of our other divisions to specifically call those families. That was their job, to get those information and call. And we have a person on site who's continued to do that. All along the way, I think one other important thing to note is from the very beginning, we were clear that the state was only funding these for 5 to 6 weeks. And that created the opportunity to build a local version of the Ngo Teams that will be able to provide additional support. And that team came together. We had a representative from the public health side working with representatives from the other side of HHS to coordinate and build a model that would, one, increase linkage to support services, also help facilitate and address the issue with families getting their results, because we shared the frustration with those on the call, as well in terms of making sure they had the proper information and the proper guidance. And they came up with a number of proposals, and I was not a part of those conversations when that team and the members of that team spoke with some of the folks, in particular from Impact, to talk through some of those strategies. So I say all of that to say that that's kind of a historical review of some of the logistical challenges that have been in place. The issue becomes, and this is not specific just to this situation, it's also specific to some of our other efforts where we've tried to launch, or we're working to launch, large-scale testing that's not tied to an appointment system. There are challenges in terms of how that information is communicated, who is the ordering provider, how that information is fed through the system and pulled by the health department as well as by the individual. In a traditional system, for example, if you go to your provider, you have an appointment, your orders, the provider who you're seeing orders your test. The test goes into the lab, it's associated with your doctor, your name is on it, your contact information is there, it's sent to the state. Then when that information comes back, it's fed to the state surveillance system, so the health department gets a copy of it, but it goes to your provider. So your provider gets it, they communicate it to you, and then you have your information the state has the information, and if you've tested positive, the disease control folks can call you and do a follow-up. In large-scale testing, that's challenging because if you've got one ordering provider, per se, that would be me, for example, if any of the county tests, there could potentially be hundreds and thousands of cases that are coming through that require follow-up, that instead of having a one-on-one conversation with you and your provider, there has to be a mechanism put into place to then be able to communicate that information when there's not a natural patient relationship. So those are some of the challenges that we continue to work through. Again, as we launch some of our other efforts, I know this will be a conversation for the zip codes and some of our efforts in terms of what we're doing to target high volume zip codes, but wanted to provide that context. The state contract ended on last week. Their funding, they had funding for 6 weeks. And from, again, the work is being done to stand up local versions of the Ngo Teams, as well as within HHS, and I'll defer to Dr. Crowell to speak more on this, to extend the contract with the ready responders, or not extend, but to create a county contract directly with them to be able to provide follow-up services. So I will stop there in terms of the historical context. I'm sorry that took a little bit longer than intended, but wanted to make sure that that was presented to guide the conversation.
No, that's very helpful. I think in continuing on the establishing context lane, why don't we hear a little bit from Impact and Jane and your team, and then we will hear from Delegate Charkoudian, who's been intimately involved in this issue, and I really want to give a lot of credit to. She's dug very far into the weeds on this, and really appreciate her leadership. But Jane, if you could share from Impact's perspective, to Dr. Crowell's point, there have been a variety of issues, and he explained some of the context, but if you could kind of shed light on what that has meant on the ground, that would be helpful.
Okay, thank you so much for inviting us to be here. And I've also asked Karen Cabral and Valerie from our team to also be here to help shed some light on the situation. And so I don't want to rehash. I think a lot of the challenges we experienced were spelled out in the multiple written correspondence we shared with you all. So maybe I'll speak a little bit to, first of all, I do want to acknowledge and appreciate, very early on when the pandemic first hit, and we were seeing the numbers of people in our network who were symptomatic of COVID. There were several people in the county who worked with us to swiftly connect us to the Ngo team. So I do want to acknowledge Dr. Crowell, Tiffany Ward, and Luisa Montero, who really worked side by side with us to get us the resources we were asking for. And we really do appreciate the Ngo team model. We think for the communities we work with, the idea of sending teams into people's home is the best way to address the many barriers that people are facing in terms of getting to testing sites. And, because a lot of the folks in our network are undocumented. We have multiple families living together in one apartment. These are folks with no health insurance, no access to a medical provider, no doctors. They don't have cars. They rely on public transportation. And as you know, many of these folks have lost work because of the pandemic. So I think we have to really be realistic about the significant barriers faced by people who live in many of these high impact neighborhoods. And we understand certainly the complicated logistics in getting systems to move in the midst of a unexpected pandemic. So I don't want to take anything away from the many logistical challenges I know the county has had to deal with. So what I will do, though, is to highlight the impact this has on the ground on people's lives when we have a system that is not adapting and responding to their needs in a way that makes sense. And so with the delayed and lost test results, as Dr. Gales has already talked about, the delays resulted in, anywhere from 2 to 20 days, people waiting to get their test results. And in some cases, tests were just simply misplaced and lost. And the level of anxiety, like emotional anxiety, this creates for people who think that they have COVID, but have to wait that long to actually get a result, was really difficult for us, our staff, and I'm looking at Val, who's been on the front line of this since day one. I mean, that's significant. And for some folks who needed the documentation of test results, they were not able to return to work without that documentation. So it had economic implications. And the other significant implication is because some people living in extended households weren't sure if they were positive, they weren't self-isolating. And we saw the infection spread to other people who were living in that same household. And then lastly, I just want to point out how much this has eroded community trust of government. Like this, I mean, to the point where like the community, just even when we were offering to connect into the Ngo team, at a certain point just said no. So the erosion of trust, I think, is really important to mention. And we have got to do all we can to try to turn that around. And so I just want to say that in addition to the Ngo teams, the other testing options also just aren't working for the folks in our network. So the Six Flags, you know, so we were told to send people to Six Flags, which is like far away in Prince George's County with limited hours. You need a car to get there. You need an ID. The county VEEP sites don't work for our folks. You need a doctor's referral. Many of the folks in our network don't have medical providers or a doctor. You still need a car. The CVS testing sites, you need a car. It's a drive-through. You need an ID. And folks that have tried that, the results they get are so darn confusing. And so Val has had to spend hours trying to get through the CVS line to get to somebody to explain what the test results mean. So we have not found that to be helpful. Private clinics are expensive and people can't afford it. And Mary Center, we can't get appointments. They're overwhelmed. And so we've really been hanging in the situation of none of these testing responses working for the community. And it's just been so frustrating and heartbreaking at the same time, because we're seeing the impact it's having on real lives, you know, in addition to the public health risk, right? And so that's, I mean, I invite Val and Karen to weigh in if there's anything else that you want to make sure is mentioned.
Val or Karen, go ahead. Val, go ahead. I think you unmuted yourself.
Here I am. Thank you, Jane, and thank you everyone for your time and dedication to this. I just want to highlight to what Jane said. It is very hard, especially when it hits home. And I do want to share an example, and that is my house. My mom doesn't have health insurance, and we had to have the Ngo team come up here to get her tested. It took her over 18 days to get her results. And we only got her results because my husband also got tested. So it is very particular when you're working with a community, because it is someone very close to you. But when it hits home, it makes you realize that the discrepancies that are going on. And the frustration just keeps growing because you have someone who's potentially sick with COVID that you may not know. I'm also working with the community, trying to, you know, give the best results that we can, trying to work with government. But at the same time, I'm also living that lack of continuous support from getting tested to getting your results. And there are plenty of cases. Dina Nelson, who didn't get his results were lost. He was told, if you don't have a fever anymore, go back to work in 5 days. And except he was actually positive, and everyone in his household, 12 people ended up being positive, including his mother-in-law, who was 70. So I know that it has been hard for county, and it has been hard for us as well. But I do agree there needs to be a better system in place, and I know we're all working towards it. I know that Karen has more information about zip codes and what areas are more affected, but I just wanted to share this example with you guys.
Thank you.
Thanks, Val. Thanks, everybody, for pulling this meeting together. We appreciate the opportunity. So at Impact, we sent 53 families to the various, iterations of the Ngo teams. It's 156 adults and 96 kids under 18. In terms of zip codes, our highest zip codes were 20902 and 20906 with 8 families each, 20901 and 20903 with 6 families each, 20904 with 5 families, 20877 with 3 families, 20851, 20853, 20878, 20912 with 2 families each, and 20842, 20872, 20876, 20886, 20895, and 20910 with 1 family each. You know, I would like to thank HHS for pulling together Monica Martin and Josue Canis once they took over the process and the county stepped in. They really were sort of on top of things and scheduling, getting back to folks, and sharing with folks other options for testing. There was still, and that happened on 5/20 is when Monica and Josue and HHS, the county HHS team took over. However, prior to that, anyone who had been tested, there was still long waits and results. And even after the county took over, there were mixed results in terms of like who received a phone call. We didn't know if people were receiving phone calls, if they were positive or negative. Sometimes they would just get something in the mail without a phone call, without direction about, you know, if you're positive, you must self-isolate and quarantine. If you're, or treatment options. If you're negative, you're welcome to go back to work, and so forth. So it was just a lot of uncertainty. And then, for instance, last week on June 4th, I sent another family over, which included 2 elders over 80. And we're told later that night, that was on 6/4 at 3:30, told later that night at 11 that the state had stopped the Ngo Teams. And so let's find another option for them. Could they go to Six Flags? I mean, they're elders over 80, you know what I mean? So trying to stand for long periods of time, and people did have to stand for long periods of time, 4 hours sometimes, to get there early to ensure that they got the appointment or that they got seen. So yeah, we appreciate the complexity of all of this and challenges, and we also feel frustrated. So thanks.
Thank you, Karen. In a moment, we're going to transition to some of the solutions as they've been laid out in the packet and as has been articulated by Impact and HHS as well in public health in terms of where we will go moving forward. But before we do that, Delegate Charkoudian, you have been intimately involved with this. You have dug very deep in terms of trying to figure out what happened to those lost tests, just one of many examples of your involvement in this. And I really want to thank you for working with Impact and HHS on trying to find solutions. We'll transition to those solutions soon, but before we do that, would you like to add anything to what you've seen, you've observed in your conversations at the state level as well?
Yes, thank you. So thank you, Chair Albornoz and committee members, Glass and Rice, thank you. And thank you also to Dr. Krause and Dr. Gale for all the work you've done to keep our community safe. I appreciate the chance to share a little bit about my perspective. And I want to start by saying that it has always been my intention to hold the state accountable and to use my role to get answers from the state and to make sure the state is playing their part in this effort. We do need to coordinate efforts for me to be effective on that, and that's one of the things that I'm hoping we can do better at. But it's also my job to advocate for my constituents. And every time, just yesterday, I got another death notice. And every time I get a death notice and look at the addresses, I know before I look them up where they're going to be. And they're in Long Branch, and they're in Langley Crossroads, and they're in White Oak. And most recently, I got an email from somebody asking for help with burial costs White Oak for her husband who had just died. And I do appreciate that HHS has those services as well. But it's I just want to start by saying that because it's the incredible suffering and the targeted way in which the suffering is happening in our communities. I'm worried about all the vulnerable communities in this county. And it's my job to be particularly worried about the ones that I represent. And so it's in that context that I have been involved in this conversation from day one, and want to continue to be part of developing solutions with all of you. And I think that everyone here knows the realities in our community, but I just want to highlight a couple of things. I think folks are familiar with the social determinants of health. I think folks are familiar with the lack of health insurance, lack of medical care, the multiple people living in very small spaces, multifamily buildings, people being frontline workers, and so more exposed to the virus. And then I would just add this piece about the limited trust in government, and especially since Trump took office, very real reasons to have limited trust in government. And then as we fail them, me being part of this government, as we fail them, we continue to create less and less trust. And I think it puts both those communities and the broader public, all communities, in more danger. And so I think we, I've heard about these challenges. I'll try not to repeat the specifics, but certainly I've been working with Impact Silver Spring. I've heard about a lot of the challenges directly from my constituents who have called asking for help. I've talked to paramedics about some of these issues and when they're coming in. And I think Mayor Stewart recently sent an email to some of the people on this call, a sort of a formal communication from paramedics, but I've also spoken to paramedics when they're coming in, when people are very, very sick and about to go to the hospital, recognizing these broader issues. And so I think it's crucial, and we've been talking about from really day 3 of this pandemic, the need to target our testing and our tracing and our support to these communities, both for broader public health reasons, but also, when we talk about equity and we recognize that it's years of inequities that have led to this place, it means that the way we start to respond to that is by doubling down, tripling down, quadrupling down the investments that we're willing to make in these communities. That's how we start to address the inequities, the social determinants of health. So we accept and we understand that it's history that brought us to this place, but that doesn't make it acceptable for us to keep going in a way that that lets these historic inequities continue to result in death and suffering in these communities more so than in the rest of the county. And so I think that, we recognize one of the things I've spent a lot of time looking into, and we've spoken, and Dr. Gale spoke a little bit about this. All of our systems, of course, are designed for people who have privilege. And I mean all of our systems, state systems, national systems, county systems. So for example, a system that requires that you have a primary care physician in order to get testing and get the responses would be an example of a system that is designed for people who have privilege. And I think, and I recognize that's the state system, and so I'm not blaming the county for that system, but I did start asking in the second week of this pandemic, what is our plan for people who don't have primary care physicians? And so I think that we understand what these systems are and where they fail our most vulnerable communities. And I think that I just would welcome the opportunity to work more closely together to figure out how do we not accept those gaps, but instead figure out how to target our solutions to close those gaps. Again, the state set up systems that have required that people have cars. And I've spent some time talking to the National Guard, to the Department of Health, state level. I'm really looking at how could the county work with them to set up pop-up testing sites. And really, we started these conversations before there were enough tests, but we knew that eventually we would get more tests. And so now we have more tests. We still need to get more. Again, I think there's opportunities for pop-up testing in neighborhoods. I mean, I think Ngo Teams in people's homes are most effective, but if we don't have access to that, the pop-up testing is a conversation we've been trying to have for 8 or 9 weeks now. And so I would, really welcome the chance to move forward with that conversation as well. I think, there's been times that Jane and I have been so frustrated. We've talked about what if I just take my car and take people to CVS in my car? I mean, we've literally thought through how could I keep the backseat of my car safe enough to drive constituents to get their testing, because that's how powerless we felt as person after person is suffering and struggling and scared, and doing the best that they can for their community and their family. So I think we know what we need to do. Recognizing the challenges, Impact did a great job. I was proud to work with them on developing, like, this is what we think a plan would look like. I think it's crucial that the system that we build involves really the grassroots group that have trust in the community. I think Montgomery County, more so than many counties, has done a really excellent job of recognizing mistrust, and especially mistrust in many immigrant communities, and worked really hard to make sure that we're responding to that in a way that builds trust. But I think that still the county is the county government, and I'm part of state government, and there's groups like Impact and CASA and Identity and others who, and churches and mosques, and who have relationships, and they have to be really the front line, the doorway, the bridge with which we engage with the community if we're really going to reach everybody. And so they have to be part of this conversation in building the plan. And then I think that the next really clear piece of it is to have an ability to test without a car, whether that's mobile testing sites or home visits. Then an ability to ensure that the information about testing gets back to HHS and then to the patient, even without a primary care physician. Again, I spent a lot of time speaking with Dr. Haft and understanding the state system to see if we could figure out where that disconnect is. And I would welcome the chance to talk more to HHS if that would be helpful. I think to bridge that gap. And then, of course, we need to connect the people. I think Montgomery Cares, we should be very proud of that. Thank you all for who have worked on Montgomery Cares system, but we need a way to connect people in a way that's realistic and gets people very quick care. And then finally, if people are positive, we need a way to work with the family to support the isolation, to get them groceries and food and whatever else they need. And if they're not positive, it's still an opportunity, I think, to connect people with other services that family might need, because it's potentially a way to connect with a family that may or may not have felt supported by the county and the state in the past. So all of that is sort of outlined in more detail in the document that Impact developed. I would just ask the county, if it's not that document, what is it? There ought to be a document in writing, so those of us who are working really hard to support our constituents know how to engage with it, so that Impact and other groups know how to engage with it, and so that those of us who are really interested in using the influence we have and the positions that we have to support you in doing this the way it needs to be done, know what the plan is, so that we know how we can be helpful. And I think that it has been heartbreaking to see the pieces that haven't worked, despite the fact that individuals, I think, within HHS are working very hard. But I don't think it's too late to get it right. I think this pandemic is continuing, as everyone knows, and will continue as we open up. I think our frontline workers and vulnerable communities will continue to be the ones who are suffering the most. And as I said at the beginning, and I'll say it again, I know the state has a role to play and can do better. But the conversations I've had with the state when I've engaged and said, how do we get this? How do we get that? The state needs the county to be asking for things. And so I can support those efforts, but I can't ask for things on behalf of the county without coordinating with the county. So I stand ready to support making this work for our vulnerable communities. I know everybody in this conversation really desperately wants to do that right, and I thank you all for that. And please let me know what I can do to be part of that.
Thank you very much, Delegate Charkoudian. That was I was mentally saying amen to a lot of what you were saying during your presentation, and I know all of us couldn't agree more with everything you said. So what I'd like to do now is transition to some of the solutions specific to the zip code work, and then we will hear from folks in the disability community talking about within their context the unique challenges facing that community, and then discuss solutions that are unique to that group. But before that, I see that my colleague Evan Glass has his hand up and would like to speak. So Councilmember Glass.
Thank you very much, Mr. Chair. Ms. Park and Delegate Charkoudian, I want to thank you for all the work and attention you've been putting into this for a number of months. right? Since this started, we all here in the county, you in the community and at the state have been trying to figure out how to make sure everybody is healthy and safe. And clearly testing is one of the ways to ensure that and to learn if I understood you correctly. And that's really what I want to do right now, is just to clarify what you were telling us, that tests had gone missing and that it was, as I understood it, it was the state that lost the tests, or we're not quite sure who lost the tests, which is why we need better documentation to understand policies, protocols. Can you synthesize what you were saying so that we can all understand the gravity of this situation? I'll start with you, Delegate Charkoudian, and then we can go to Ms. Park.
I think in terms of the gravity, I think its impact, who knows who was in the individual's homes. I can share what I know. Probably Dr. Gales can shed some light onto this as well. It's my understanding, I spent a good bit of time talking to the ready responders and then to the Dr. Haft about the state lab. It's my understanding that the process is essentially the Ngo teams were going into the homes, taking the swabs, dropping it off at the Dennis Avenue facility. Things would get picked up from there within a few hours and go to the state lab, which is in Baltimore. Then they get entered into the system. And then the county would have access to that. I think a piece of the disconnect is, in a normal situation, as Dr. Gale said, it would be a primary care physician who would do the prescription, and then it would be that same primary care physician who would receive the outcome of the test. And in this case, it is a ready responder physician who writes the prescription, someone who works for them. And then it is, I think, Dr. Gales or someone within HHS, and they can clarify who is in the system as the recipient of the test results, because it has to be a physician. And I think, so it's not clear to me, and this was part of what I had asked to hopefully be part of the conversation around. It's not clear to me when the statement sort of was getting made, the state's lost the test. It's not clear to me where in those 4 sort of steps of the process the loss is happening. And I think some of the problem has to do with this piece about systems that were designed for primary care physicians. And it's an example of a place where we need the state and the county to be engaged in conversation, not necessarily in a sort of blame and finger pointing, but like, so where, here's the 6 steps. Now we all understand them. So which place in these 6 steps is it actually in the state lab where something goes in and doesn't come out, or is it somewhere in the computer system? I think, and again, I haven't had a chance to have this conversation directly with Dr. Gales. He may have some insight, but I do think it's an important piece to understand. And also, especially if, even without the Ngo teams, if it's some other testing, if it's a state system that's going to be managing it, it's worth all of us understanding what those steps are, who the names are in the system that receive the results, and then what the plan is for how the results get from that person's computer to the person who needs the answer, and then ultimately to someone who can take care of them physically.
Sure, and I completely understand that we don't have the answer to those questions, but I really appreciate the committee chair for scheduling this on our first real committee session since this crisis began, because these are questions that need to be answered. And again, I go back to the opening statement I made, where I really appreciate you and the team at Impact Silver Spring for identifying this and trying to work through it. And so now we're having what very well might be the first public conversation of this. I know there's been a lot of correspondence. Some of it has been buried in email and in the moment, but this is extremely important and worthy of this public conversation so that we can figure out where the gaps were. And then so Ms. Park, so from your perspective in working you and your team working in the community, I mean, give us an example that someone has a family member who's sick, they try and get tested, and then they just never hear back.
Yeah, so basically, and this is, and maybe Karen, I'm gonna ask Karen in 1 minute to kind of back me up on this, because she was really the main person helping to coordinate all of this for us. So, and one of the gaps that we experience is that there was nobody at the county level serving as coordinator between the Ngo team and us. So we ended up having to be the direct connect between the families and the Ngo team. And that took an enormous amount of work, just the logistics and scheduling and making sure Ngo teams, I mean, it was enormous. So that is one gap that we identified, is because there wasn't a designated county coordinator. I think that contributed to things falling through the cracks. So, you know, families would get identified through our network. We would connect them directly to the Ngo teams and do all this work to schedule the visits. And then as far as we were concerned, once the tests were taken, we were just assuming that the families would receive their results. But then it ended up happening that days, weeks later, we started getting calls from our network members. Val, others on the front line were getting calls saying, where are my test results? And that's when we had to like try to figure out, like, where are the test results? And I guess that's the conversation we're having now, is to sort of unpack where things fell through the cracks. But it's created a lot of complication and stress for us. And I'll say that, you know, I keep hearing repeatedly from our staff that they feel it has impacted our relationship with community, not only contributing to erosion of trust with the government, but we spend years building relationships with the folks in our network. And when something as critical as this fails to come through, you know, it hurts.
Yeah.
It really hurts.
Your entire organization is built on building trust
Yes.
between communities and government.
Yes.
And for this to happen, a life and death situation,
Yeah.
and for people to feel like they're left holding the bag.
Right.
I get that. Deeply personal, and your entire mission is on the line in that instance. And then before I just ask Dr. Kroll if he could help fill in the gap, you know, the point that I think Delegate Charkoudian and you had made, Ms. Park, earlier about systemic, I'll say systemic racism, the systemic inequities that we have. Clearly, the same communities that have higher rates of COVID-19 are the same communities that have less access to healthcare, less access to food, less access to a lot of things. And to think that it's the inability to have a primary care physician or somebody who is in contact with them to give them their results is a colossal failure on the system at large. To rely on something that there was no reliability to begin with. And that's not an indictment of us here in this conversation. That's an indictment of society and 400 years of systemic racism in this country manifest itself in this moment. Important point to note. So Dr. Kroll, where do you think some of these missteps or gaps have occurred?
You know, I could go down that path and talk about the litany of things that I think were challenges. Let me just say to both Jay Park from Impact and the team at Impact and Delegate Charkoudian, thank you for the dedication and constant support around this. And I think that the issues you've raised, I think, were things that we discussed several weeks ago. And some of those things I know that, and Dr. Gales may be able to speak to this, kind of worked through to try to to fix some of the things that were broken. I think that I said earlier, well, let me one more thing about this, and that was that one of the most painful moments for me in this process started with the first call I got requesting burial support for a family member. You know, that rocked me and a bunch of folks back on our heels. Even though we have a burial fund, it's not something that I think about often, and those calls have been coming in a lot more frequently than they have in ever before in my time here in the county. You know, I think everything I said earlier, everything that we do is and have done has been a new thing, and we, you know, Delegate Charkoudian talked about the systems were designed for people who have privilege. The systems were designed also by people who have privilege and who think about things from a perspective, but not necessarily the perspective of the people the systems are designed to serve. And so when we get into one of these situations, in this situation, where all of those errors in thinking and logic and incomplete thinking get revealed. So we set up testing in VEEP centers where drive-through presumes people have cars to drive through and that they can get there. Presumes that we're not talking about 80-year-old people who can get there, who can't get there, who need somebody to come and get there. We stand up Ngo Teams, but the normal process is a primary care physician referral, which was part of that, as I recall, the CDC guidelines or the CDC expectations around testing. Those things didn't take into consideration the folks who had disparate, who had poor access to healthcare through the long-standing disparities and racism that we've talked about a lot in the last several weeks. I think it's reliance on a system that was probably cracked and fractured and inadequate to begin with. And now that we are pressing it and stressing the system, we see the challenges. Even in the county, we've spent years building the Montgomery Care system and our network of providers who, when this pandemic erupted, many of them had to stop the service, shut down the service, transit, because they had doctors who were vulnerable, who were themselves in a vulnerable category, and they didn't have adequate supplies or weren't set up in a way that they could withstand that process. So the normal folks, the normal group that we would have reaching into the community and engaging with the community were offline. And as a social safety system, as a social network, the safety net, I think of the providers that we have relationships with in HHS as part of that essential safety net, which means they need to be there. And we need to find a way to make sure that they're there. It took them a while to get back online. They've come back online in recent weeks. So that is at least something. And then I think the other piece of this from my perspective is we have had good network relationships with the provider community, the partners and the advocates in the community over the years. And they have all known how to reach into HHS to access the services that are needed. This put a different level of stress on that because we've got families who have multiple needs that I think whereas normally they could call in to a place in HHS, now they're having to call and reach across multiple parts of health and human services. And that system is one that has been a challenge to put in place. We started testing and we were thinking about testing, and testing was the priority, and everybody's thinking was about testing, but not so much about the human service piece that has to surround and accompany the testing pieces of this. And I think that's the piece that Jane Park and I had conversations many weeks ago before we even started this process with the Ngo Teams about trying to get families connected to resources. As Ngo Teams stood up, we started thinking about testing for or human service connection with Ngo Teams, and that was where Monica Martin joined the mix to try to make sure that as we tested, we had a link back to HHS for the other services that families needed. Whether they tested positive or not, they had needs, because this is both the economic impact as well as the medical impact. So all of those things are just dots in the place in the system that we stood up something, and now we're having to go back and connect, fix, and repair once again on the fly. And I think that's, and we have, every problem we've fixed has created another problem. And the best example I can think of is the fact that we had overcrowding in the zip codes and in the populations and the communities that we were testing in their living environments. And so they needed some isolation. So we worked to try to stand up quarantine hotels, et cetera, for folks. And that in and of itself created another thing that had to be stood up, and another challenge that we've had to solve. And they're still working to try to solve that.
And there's been no shortage of challenges. We all understand that, a once in a lifetime situation that we're trying to work through. But when you couple a once in a lifetime generation with the inequities that have been around for generations, we face this compounded problem. And so I really appreciate Impact's work and Delegate Charkoudian's attention to detail and asking the right questions that we are committed to trying to figure out how to continue making our residents safer. And unfortunately, those who are most impacted continue to be impacted.
So let me just say that I think you're right, Councilmember Glass, and I think that what I think we are learning and doing on the fly, and I will preface it by saying that no matter what we do, it will not be fast enough for anybody in this room and anybody around the county. So I think we are still struggling, and we're going to see more folks affected by this before we're done. I think that a couple of things have happened that I'm pleased to see the development of, and one of them is the development of consolidated hubs and across the county. Whereas before, we on the provider side and the community side, where we were working with providers who are doing their thing more often and independently, they've come together now in some ways to try to consolidate their resources and their support for families. So it's food, it's diapers, it's help, respite support, relief, all of those things coming together. And on our side, we're trying, on the human services side, now trying to marry with that so that as family members are identified in the community, there's a central point where we can bring human services supports, the social determinants of health supports that we offer to that same partnership. And as we stand up testing, to make sure that all of that is married together now. So the Ngo Teams represented for us a particular strategy for getting into the homes and getting folks tested and getting them connected. I think it has always been it has a limit, and that is the number of people that a Ngo team can get into the home to test at any given time. Because once you're in a home, you're testing multiple people potentially, and working with them one at a time, in a way that requires the team go there, test, et cetera. So it has this purpose and has a place. I think that and we're working now to continue that and to restart that and expand that capacity a little bit. The CE and the county administrative officer have given HHS some authority to do rapid procurement of services, and so we're working with the provider ready responders to bring that back online. I think the other piece of this is in reality being able to stand up broader scale testing and take it to locations and do the pop-ups that I think we've all been talking about. And that's our other priority in this process, is to get that online and up and running as quickly as we can.
Very good. Thank you all. I'll turn it back to the chair. I know that there are a number of other items on the agenda.
Thank you, Councilmember Glass. Good questions. Councilmember Rice would like to chime in, and I know Dr. Gales had a response that he'd like to follow up on, but I'd like to go to Councilmember Rice next.
Well, no. Let me defer to Dr. Gales, because I think
Okay.
Dr. Gales' comments would be important. Thank you.
Oh, well, thank you. Happy to yield the time back to Councilmember Rice. I'll save that for tomorrow's conversation. I just wanted to provide some clarity on a couple of things that I think will inform how we move forward. So I think part of the challenge has been that the ready responders were a state team that were basically given to us as a local jurisdiction in terms of working through. And so in terms of certain authorities, in terms of how to fix those processes, we did communicate directly with the state and directly with Dr. Haft. And the coordinator, Ppe Challenges, was the coordinator for the Ngo Teams, working to schedule the families and communicating with Sante Jackson, who was a team member on our side, who served as a coordinator and has worked tirelessly and served as a point of contact with Impact and other agencies, as well as services and implement homework since to coordinate things. So we have, as Dr. Crowell pointed out, lots of these systems are new. And some of the traditional partners that we have historically, well, we can't say historically utilized in this setting because this is the first time this has happened. And so, when we have had a response, so for example, we did start the alternative test sites recognizing there were limitations in certain spaces and places, and created multiple sites for people to use. We recognize that still created limitations for folks to get into, one from a transportation perspective, but to the earlier question about needing a referral. So we created a mobile helpline so individuals could call. And in fact, I think my name is on the standardized order, so if an individual calls in, they can get that test under my name and go through, so they don't have to have a medical provider anymore. And I think that system's been in place for almost a month now. And we have seen people utilize that. And to speaking to how to move forward, certainly we share the concern in terms of how to expand capacity that is more geographically available, less invasive, as well as creating opportunities for high throughput options. I don't know how to best describe it, but there are lots of, as pointed out within the situation with the state, there's lots of logistical issues and things that go in terms of into how you do testing and do, you know, whether it's low volume or high volume. And we have an option now that we've explored and hopefully finally at the point to be able to move forward is a high throughput option that is less invasive, that requires less intensive staffing, less intensive personal protective equipment, that would allow for us to be able to do more pop-up venues and testing options for folks. In addition to that, we are not, I think the ink is not dry on the contract yet, but we have actually been working with an agency to provide volunteers who are healthcare providers to be able to go through and provide mobile testing. One of the things that we did is we identified the top 10 zip codes that have had cases and paired that with a similar analysis that we did approximately a year and a half ago, because from the public health perspective, we've been committed to looking at health disparities and telling a different story. And so we paired that zip code analysis with those top 10 zip codes. And we haven't released that publicly, but we've been looking at, okay, we know where the most cases are. And unfortunately, those same zip codes score worse in terms of looking at health outcomes, access to care, all of the things that we've talked about, social determinants of health. So that is a shared space that we have. And our next step is to say, all right, who are, again, building on community partnerships, who are the key community leaders and stakeholders within those respective zip codes who have the authority, who have the trust, who have the know-how in terms of engaging residents in those spaces, to identify places for testing opportunities, to identify crucial needs in terms of what additional services people need to be linked to, so that we can drive these numbers down. As we reopen, and sorry, let me take a step back. The other thing that is part of that high throughput testing option, and the council members are aware of this, others on the phone may not, or the call may not be aware of this, is we originally created the notion of doing this in phases, identifying individuals who are first line responders, essential employees, and asymptomatic individuals who were connected to known positive cases in terms of getting testing, because we do recognize that part of the factors that have driven more cases in certain communities is high congregate living, the higher percentage of folks within this county who are essential employees. This is to Delegate Charkoudian's point earlier. These are the same things. We know people are having to go out to work. We know people are having to utilize transit to get to spaces, so they're more exposed. And so we identified those folks as high priority folks for our testing mechanism moving forward. In addition to that, I sent a memo to providers in the county over a month ago now when the CDC changed their criteria to recommend that asymptomatic individuals be tested, and included that language to recommend that they test folks in their offices as well as in their provider networks. So I think these speak to some of the later agenda items in terms of our strategies moving forward. Additionally, we have impaneled a panel of healthcare and public health experts to provide additional guidance in terms of our metrics for reopening, as well as discussing other strategies of outreach from an Ppe and a public health perspective in terms of how to address the burden of virus in these particular zip codes and communities so that we can drive the numbers down.
Thank you, Dr. Gales. Councilmember Rice?
So I'm actually thinking about a whole bunch of different directions as we're talking about reopening. And so that's a part of this whole concept of adequate testing as well, and making sure that folks understand. And it was a story, and I can't remember who had said it, whether it was Jane or whether it was Valerie, who had talked about the story of the person who had gone back to work. Well, in Montgomery Village, we had a great story and a great example of where the failure in the system is, to where a person actually continued to go to work even though they felt a little bit sick, but the company actually insisted that they come to work. They needed that person to be there, and actually ended up causing a huge health scare for every single employee there at that Montgomery Village McDonald's, as well as, unfortunately, a number of his family. He unfortunately died and ended up infecting a number of members of his family. And I'm intimately involved with that situation. So I know all too well about, and that's been my conversation with Dr. Gales, has been that when you talk about systemic racism, when you talk about the effects of it on our healthcare system, the reality is that the very nature of having your overpriced coffee at a Starbucks or your overpriced McMuffin are the very things that are putting our people of color at risk. And so as we push to reopen a lot of these facilities, the reality is the people who are working there are low-income people of color who don't have access to healthcare and are the ones who immediately are then impacted by the fact of their ability of not being able to access the level of testing that's necessary to ensure their safety, nor the precautions that are necessary in terms of what they need to do to protect themselves. And Dr. Gales knows I've had this conversation personally about my wife who owns a hair salon, and we talked about this intimately about why, in fact, across the country, we chose the industries we did to reopen first. It ties directly into our health. And so as we transition into moving forward, I appreciate how Dr. Gales has been approaching this in terms of using that also as a metrics to be able to say, well, let's think about this and look at this with the racial equity and social justice lens. So I want to say that part. Let me talk about testing, because since the very beginning, one of the things that we as a council have pushed for, and Councilmember Reamer, actually, to give him credit, has been at the forefront of leading this, has been insistent upon testing. The reality is that when it came to the federal government, nobody had access to tests. I remember when we first had the conversation, we said, look, how can we get tests? And Dr. Gales, Dr. Kroll told us, we don't have access to them. The federal government's trying to get them. The state is trying to get them. We'll see what we can do. Then it came, okay, the federal government's now got something, and I'm transitioning into late March, early April. Federal government's got a hand on some stuff, and they're going to start disseminating that to states, right? To then disseminate to locals. So then at that point, it was, okay, so we're going to try and get our fair share. So everybody's like, how do we get our fair share? And Dr. Gales, I remember those conversations, right? We can go back and listen to the tapes where it's like, you know, we said, hey, we want to have these tests because we know that there are going to be people that are going to be impacted. And we talked about, because, you know, Montgomery County actually has been on the forefront of talking about our racial inequities when it comes to social determinants of health. I mean, we just had the report at the end of last year that Dr. Gales authored. And so we knew that this was going to be the case. This wasn't a surprise to anyone. And thank you to Impact for highlighting, lifting up that work and being a part of that work. But you know intimately that we've been talking about this for a very long time. So this was no surprise. We knew that these things were going to happen. I grew up in 20906, right? So I know that's home to me. So I know that district intimately. So then when the governor then announced, okay, well, he's going to have these 500,000 tests, right? So we kept saying, we don't have enough tests. We don't have enough tests. All we can do is healthcare professionals and first responders. And that's the top tier. So we knew nobody else was getting tested anyway. So we knew that there were asymptomatic people walking around infecting other people. It was happening in our communities of color. And it was just that, you know, folks were like, look, we just don't have the test. Then it was, oh, well, we're getting 500,000 tests. And everybody's like, yay, I can take my foot off the gas a little bit because these tests are now here. Photo op at BWI, everything's going to be great. And so I want to say this because I think that this is where the mea culpa moment comes in. At that point, think about two fire engine companies that are responding to the scene of a house fire. And once one of the engine companies get there and says, yes, we've got hoses on the fire, and they slow down a bit, right? So they don't run every single red light. They don't do all the things because they know that that engine company's there. Well, that's what happened in this case. And so folks said, okay, we've got these 500,000 tests. You know, we can relax a little bit. We're going to have the test. We'll be good. And those never came to fruition. Still today. 3 days ago, I had a constituent ask me on Facebook, they're like, so whatever happened with those 500,000 tests? And this is a person who's actively engaged, right? Who's on Facebook, who interacts with me on a regular basis, asking me this. So imagine the person who's in Montgomery Village, right? Who has English as a second language, who just assumed that there were going to be a test available for everybody, who's continuing to say, what happened? I saw on the news one day, a month ago, that these tests were going to be there, and why don't we have tests available? Well, and folks need to start saying that, look, for us, we didn't have access. We need to be very clear about the fact that we didn't have access to tests. And even now, the tests through CVS and all those are coming via state. We haven't had the ability to actually procure a significant amount of tests ourselves as a county. And if I'm incorrect in that, I'd like to have Dr. Kroll or Dr. Gales correct me. But my understanding is we still have had the majority of our testing come through the state. And so because of that, we obviously are then going to fail all of our communities of color, all of our people of low income, all the people who don't have access, all the people who have the negative social determinants of health. All of those are going to happen as a result because we don't have that strategy. Because if we had that flexibility in terms of the access to be able to have our own tests and set up our own in significant numbers, I'm not talking about just a few, but in significant numbers, we know we'd go to the only mobile home park we have in the county in Germantown, right? We go there. We go to Long Branch. We go to Burtonsville. We go to some areas of Silver Spring where I went to school at Blair. You know, we go to some of those areas where we know, right, the highest incidents are, to Montgomery Village and all those places. So I'd like to just ask Dr. Gales and Dr. Kroll to comment on that piece in terms of our control and access to significant testing.
Sure. Well, that's a great question and a great historical perspective of how testing has evolved, both including the formal and informal comments. I won't provide any further commentary on that. But what I can say is this. So the test sites that we have stood up have, the state did make those provisions in terms of the vehicle emission station and so forth. The additional sites that we've added have been brokering partnerships that the county has with private laboratories to be able to expand. And as we have grown, we've expanded capacity at each of those sites. In addition, the county has brokered relationships with other labs to be able to provide additional resources. Now, the state has recently made provisions to allow for sending a percentage of test kits through their relationships with private labs over the last week, and we continue to leverage that. The challenge has been this in terms of doing a lot of the pop-up testing, and this gets back to one of the earlier points. To do pop-up testing and be able to respond from a mobile perspective using nasopharyngeal swabs is a little bit trickier and challenging. So before we explore the option of the high throughput self-collection kits, that's where we were building this mobile testing arm, which we are close to finalizing and again, being able to move forward. And that would allow for us to go to those different places that you mentioned, identifying those high volume places to do testing. So the mobile home park in Germantown you mentioned, there has been multiple conversations in planning to do just what you said. In fact, Dr. Kroll and I had a communication last night about that, about being able to move forward. The community partners have been engaged. I know of at least 2 conversations that have been had in terms of planning, including working with the community folks, as well as one of our Montgomery Cares partners to be able to pull that off. I think if today's Thursday, that would have been on Tuesday, I had a conversation with Mayor Stewart in Tacoma Park, where she and her staff sent forward a list of potential venues that are readily accessible within the community to do mobile and pop-up testing. And I know she included additional folks. I know Delegate Charkoudian is on a follow-up email that she sent. I'm not sure, I don't remember who else is on there. So I say all that to say that we are working to, as you've heard me mention in our call from Tuesday, I'm not saying aggressive, but we're being very active in terms of throwing the kitchen sink in terms of testing out to these high volume zip codes. Because I do, as you mentioned, as we move forward and as we open things up based upon the data, I want to make sure that we have driven the numbers down as much as possible because of, in addition to all of the things that you mentioned, in terms of how it disproportionately impacts communities of color. If we get the numbers down and we get people tested quickly and we get them isolated quickly and we get them quarantined for those who are not for those who are contacts, but also get them tested, this will help flatten the curve for all of us. And that, so I say all that to say that we're leveraging all of those testing resources, whether they're nasopharyngeal or oral collection. Our team in public health has been tasked this week with identifying as many venues as possible, working with our colleagues in HHS in terms of also standing up the social support component. So hopefully by next week, we will have at least scheduled testing opportunities at all of the respective venues that you just mentioned. Because it's important to be able to be nimble in that response and offer, to all of the points that have been brought up before, offer testing in spaces that are accessible whether we're talking about needing a provider, insurance status, transportation, et cetera.
So to that, let me just add something about this. Everything that Dr. Gales has said is accurate in terms of where we are with this process and what we're thinking about moving forward, especially with Councilmember Rice, your comment about Middlebrook and getting that community addressed, the needs of that community addressed. One of the things about this and testing has been a learning experience for me, and I think for most of the rest of the country. But one of the things about testing is that we when the governor announced that we had 500,000 tests, people might have said, "Oh, great." Having 500,000 tests is not tomorrow we're testing, and I think that is one of the challenges that we didn't understand. And I think the governor didn't understand that necessarily. They had 500,000 tests, but didn't have a couple of other pieces in place that absolutely had to be part of that process, because it's not just the collection mechanism, it's also the lab and all the nuts and bolts that have to go into that. And as we stood up testing, it's also a change in how you test. I mean, when we started, it was nasopharyngeal, and it was primarily medical teams that had to do that piece with a lot of different kinds of gear and support. It's shifted. And I think as we shift and can go to broader scale testing, that comes with a whole lot of pieces, nuts and bolts that have to get put in place. And the frustrating part is for all of us, for me especially, is that takes time and action and work and calls and meetings and more stuff and all that stuff that has to happen just to be able to be able to offer that first test. And I think it never happens fast enough for anybody, and I'm certainly included in the number of folks that are impatient and want that to happen. It is happening as fast as we can make it happen, both certainly at the county, and as we get better, get those things in place, the testing will speed up, and we'll be able to reach out even more of the community. So that's the one comment for me about the one thing I wanted to add to the question in response to you, Councilmember Rice.
Okay, so I think everybody feels the same urgency. We all have that context. We all agree that testing is a key component, and making sure that testing is as easily as accessible, and that the process is fluid, and that there's follow-up. All of us agree there, but that's just one component of what will be necessary moving forward. And there will also need to be case management as we track these families and the holistic needs that they have beyond just the pandemic and COVID. And so I have a general question, acknowledging that bandwidth and capacity is a huge challenge. But Dr. Gale and Gales and Dr. Crowell, do you have the staff that you need to be able to execute the plan that has been laid out by Impact, that will require an expansion of partnerships with other nonprofit organizations, which will require more contact tracing, which will require case management? Do we have the team in place currently to be able to execute the plan that I think makes sense and that is going to be critically necessary moving forward?
Two-part question for me. One of the things about this is that we have about 1,700 employees at HHS that have been on telework assignments out in the community, some still frontline, and redeployed to manage and work through the pieces of the pandemic. And we have pulled people from left to right and assigned them as needed. The short-term answer to that is I think we have the capacity to do some of the coordination and response that we're talking about now, from HHS to the communities. One of the things we're working on with the hubs is to make sure that we've got people assigned to each of those hubs. The hubs are going to be crucial to this, I think, because it is, do we have the capacity to respond to every provider, every advocate individually? I think the answer to that is a resounding no. And it won't matter how many providers there are. If we can get the partnership and the coordination of that through the hubs, then I think the answer is there won't be enough. Or enough responsiveness to folks, I would say it that way. But I think we have the capacity to do some regional work and to build some partnerships with communities in regions. And I think Up County, the Consolidated Hub at Black Rock is kind of the model for what we're thinking about now. And we're working, I know, across the regions to try to build that capacity. The longer term question is more difficult, obviously, because I think that longer term, depending on what the schools do, depending on how long this goes on, we have to think about how we reopen and redeploy people across the system. That requires that we begin to reconfigure HHS staffing and rethink who's available and what we have available. As staff go back to their original jobs. So if the schools open up, we've got a challenge with our school health staff and them having to go back to schools and us having to continue to respond and at the same time. So I see some challenges on the horizon. I think in the short run, we can stand up a lot of the things that are in this the document that Delegate Charcuti and Impact put together are things that we are working on. And I think we can do some of that in the short run. Yes, so I'll just stop there and say that.
Thank you. Dr. Gales, did you want to add anything?
Sure, I'll just be very brief. So the two staffing components, so the short answer is yes. And we have active plans to recruit more people. On the contact tracing component, as of now, a significant number of our contact tracers have been our school nurses that we have used since they've been out of school. They have been trained, as you know, as you've heard before, the state's larger contact tracing effort went live last week. Montgomery County went live on this past Monday. The state hired over 1,000 individuals to provide the initial contact tracing efforts for many of the jurisdictions. We have over 70, actually probably more than that, closer to 90 to 100 staff who are working on contact tracing. We are pursuing, the paperwork went through yesterday, a contract with a broker to hire additional staff to come on to provide initial support. And then as the school health nurses phase back into their respective jobs in the new school year, we will hire additional staff to be able to support that. Now to the question, and one of the things that I want to mention is that, and I won't mention the agency name because we haven't had a conversation yet, but we are meeting with one of the larger community agencies within the county and the state to discuss how we can hire and partner together in terms of securing contact tracers who are have experience working with many of the communities that we've talked about on the call and the zip codes that have been discussed. And we're excited about that opportunity. So we will grow that workforce in that perspective. In terms of the other component that I think is important in terms of executing this very active approach that we're taking in the next couple of weeks around testing. We are again at the final stages, hopefully. I will say this, I have, as a clinical person who's not from government coming into government in the last 4 or 5 years, I've had to learn a lot of patience in terms of processes and so forth. And so I think we're at the final stages in terms of solidifying the partnership with this respective agency and organization that will provide a number of volunteers that will be able to basically staff our mobile testing arm to go out and do the pop-up testing that we've mentioned to further supplement the staff that we have in place at the alternative test sites as of now. In addition, one of the other things that we have are working on and finalizing is being able to have 2 mobile units that we're working with CDC and HRSA to be able to station within the county, 2 of them in the county, to help support the hub concept and framework that Dr. Crowell has mentioned. So I say all that to say that as we stand currently, we have plans to actively recruit and bring in additional staff from a contact tracing perspective, as well as a testing perspective. And I think those 2 components, at least from the public health response standpoint, are the most important components to move forward.
So what I'd like to do is this: we could talk about this all morning, but as a follow-up to this discussion, Dr. Crowell, I think you had mentioned that we are going to get a formal responses to the questions that we had posed in writing at some point soon. I know that the county executive has put forward action teams in key categories as we talk about reopening, and I echo Councilmember Rice's comments, how ironic it is or troubling it is that we're discussing opening and yet having this conversation right now, because it sure doesn't feel like we're ready. And so what I'd like to propose is specific to this discussion, and we're going to discuss the disability community in a minute, that as part of that team, Dr. Crowell, maybe we dedicate a subcommittee specifically to this work, and that we have a meeting as soon as possible and invite Delegate Charkoudian, Jean, others who have been intimately involved in this, and my colleagues who are interested in this issue as well, and I know you are, to have a more defined strategic planning session and include people from the second floor in that discussion. And let's set that up quickly. So Linda, as a follow-up, that's more of an operational meeting. I don't know that it needs to happen in a session, but just to talk about moving forward with the recommendations and confirming what's necessary for us to be able to move forward. So I want to thank everybody for your questions, thoughts, comments. This conversation will continue. It's been extraordinarily helpful. You're more than welcome to stay on because a lot of the same issues cross over into our disability community. But I now want to shift to that component of this discussion. And we have several layers here, very similar to the systemic issues that were occurring in these particular zip codes. We've had systemic issues within our group homes. There are over 300 group homes in the county. We have a tremendous amount of incredible providers, and we know there's a significantly growing percentage of our population of people with disabilities who are aging out of systems and are desperately needing care. We have parents who are often taking care of these loved ones who are elderly themselves and are in at-risk categories. And so we've seen, just as we've seen significant challenges, we've seen catastrophic challenges within our group homes, which has been very difficult to process. And so I'd like to turn it over to the three representatives that we have here from the disability community and specifically representing some of those group homes. Rick, I'd like to start with you. If you could give an overview similar to an overview to provide some context on what we're seeing within the group homes, acknowledging that a response, there's some urgency regarding the response in this space as well, but also we're going to need to have some ongoing issues about some of those systemic issues. But Rick, if you could please start us off, and then we will hear from the other representatives as well.
Again, thank you for the opportunity for being here. Appreciate the time to speak to everybody. So I guess the oversight or overview of the group homes is that, like everybody, our biggest issue. So probably in early March, most of us closed our day program. So around March 16th, most of us closed our day program. So individuals were, basically shelter in place at the homes. Lack of PPE equipment across the board was the biggest initial issue. We didn't have any access to surgical masks, gowns, face shields, a lot of the stuff that we have now, we did not have access. People were out there, looking for suppliers, and like everybody else, we couldn't find suppliers, or if you could find suppliers, you were not going to get those because they were going to the hospitals and those types of centers first. So we were looking at cloth masks. So cloth masks was probably the first thing that went out to the staff and the individuals. The lack of testing, as I think everybody's heard, was a big issue. Many of our individuals, when they would call, they try and get a test, or the staff try to get a test, unless they were displaying significant symptoms, they were not going to get a test. We unfortunately had a staff person who passed, and we actually had two staff people pass, one individual. The one staff person called their doctor. The doctor didn't feel that his symptoms were significant enough to get a test, and 4 days later he passed away. It's almost a similar issue with an individual. An individual we supported got a test. Actually, was mostly asymptomatic, and then 4 days later, that's that individual also passed away. Lack of tests. So a lot of us did the shelter in place. The day programs closed, lack of PPE. So it was almost like the perfect storm for the agencies, because by time many of us were trying to understand what the Ngo Teams did and the ready responders, we really didn't understand the process. We learned that process, but by the time we got access to that, it was May. Late April, early May was when the Ngo Teams and ready responders. Compass had a Ngo Team. Chrissy had a Ngo Team, and Jubilee actually had a ready responder team. We had significant There was different, I guess, outcomes to those team responses in the meetings that they had. I mean, I can go into detail on that if you want. Yeah, for Compass, Steve actually had to step away, so I actually have a email of what his response and the outcome of the ready responders for him. So I think in general, the PPE equipment, the lack of testing, asymptomatic results, or not being able to get testing, and then by the time we had all that, it's in May, and it's already here. So there's there's a few providers that have had close to 20 some individuals with positive cases, 20 to 30 staff people with positive cases. Most of us seen a peak in late April, early May was when we started to see a peak. And the last couple weeks, most of us are starting to see either zero cases or very, very few cases. So we feel that that we've got through the initial part of this. And again, the PPE equipment start to come in early May. So it's not unusual to see the change in the results because that's when the PPE equipment really start to get in place with the agencies. What we think, obviously, I think you take the flip side of that is what would need to be in place for us to prevent the next wave or surge. Rapid, again, everybody's been talking about rapid, easy access to testing. The mobile testing would be very beneficial. Robust supply, a solid supply chain of access to PPE right now. Most of us have surgical masks, N95s are still somewhat challenging to get. Gloves are, for us, or we're starting to see, are the most challenging piece of equipment. Them and gowns are the most challenging piece of equipment that we're having a hard time getting access to. The other thing that we're working on, but we're not sure if we can resolve is, as you know, many of our residential situations, they're congregate care. You have 2, 3, 4 individuals who live together. And then you have anywhere up to, 3 or 4 staff, up to 17, 18 staff people that are visiting or doing direct care services with the individual. And then in many cases, you're not going to be able to practice social distancing with that because you're doing, personal care for with the individual themselves. So cross-contamination is the issue. Obviously, I think people are very aware this is a low-paying job. Most of our staff, it's not unusual for them to work 2, 3, in some cases 4 jobs in shared providers. So some of the providers have been sharing the staffing relative to that, just so that we can understand relative to communication, relative to communicate to each other. But we're still working on the cross-contamination, and we're not sure if we can really resolve that because it becomes, an income issue. People are working those 2 to 3 or 4 jobs just to make ends meet. So I'm not sure if Chrissy has any other updates. Some other things that we've talked about, again, I think PPE training. We talked about a recovery center. So there's been some discussions with Odile and Kim and Beth relative to a recovery center. So there's some initial discussions there. David Irvine, who's the Chief Executive Officer of JFGH, he's on one of your subgroups, along with Chrissy and I are on different subgroups too. But he's actually working in more detail on the resources that would need to be in place for what we call what's next. So that it's in, because reopening for the providers really has never been a part of what we've been, because we've always been open. So it really is what's next, and how does the opening of the community affect the individuals and the staff that will be accessing that community.
So Rick, really quick, I know Dr. Gales has to leave. Dr. Burgers will stay on the call and will be able to continue to represent public health. But before we get to you, Chrissy, I know Dr. Gales wanted to say a couple of comments before he bounces off. I do want to note to Rick's point that the lack of training and no fit testing has been an issue that's particularly been pointed out by our group homes. the PPE you just heard remains an issue. And although we are distributing PPE, which is a huge help, some organizations are getting, have a stockpile in some areas, but then lack other areas. And so there's a cog missing there in terms of the distribution. And another issue that's been raised, which is significant, is just really needing more guidance on metrics. We're providing metrics to so many different unique sectors, but particularly within the disability community, having people come and visit. It's just having something more specific is an issue that's been raised. And then finally, we've heard about the testing, but as we know, particularly folks in group homes, many of them are not mobile. And so we have to have testing specifically within those locations because they can't travel. Even the pop-up locations are challenging for folks in these communities to be able to get to and from. So those are some of the 4 overarching issues, but in your closing comments, we are going to continue this discussion, but Dr. Gales wanted to hear directly from you in terms of some of your responses to those concerns and questions before you have to jump off. And of course, Dr. Crowell and Odile and Dr. Bridgers will stay on.
Sorry, I forgot to unmute. So Chrissy, sorry for jumping in. I do have to jump on a state call. But first and foremost, I want to say this is, again, one of our priority communities. Thinking back to over a month ago in May. So I wanted to make one comment to Rick's question in terms of why the time frame. So similar to what you described is a situation that we experienced with our nursing homes. It was unfortunately not clear to any of us that, for example, asymptomatic individuals could transmit the virus. Unfortunately, it wasn't until early May that that data was released to suggest that they could. And as many of you know, when that happened, that's when we saw the advent of face coverings. We saw the Secretary Neal put out the directive that required PPE in nursing homes and other places and created those tougher guidelines. And you're right, unfortunately, in many of those situations, the virus was unfortunately already present in a number of places, and we've been playing catch up since then. And to Delegate Charkoudian's point earlier, in terms of things that keep people up, that's the thing that continues to bother me. I wish we had been able to contain that, because when I looked at the numbers, it's high, and that bothers me, and that's always going to bother me. And so I say all that to say that since then we stood up the Ngo Teams. I'm proud to brag on our A&D colleagues. They were the first ones in the state to do so in terms of being able to provide that additional level of support. The PPE challenges are real, so I recognize that there are some surplus in some areas and shortcomings in others. Those distributions are informed by our supplies. For example, in the beginning, masks were in short supply, and then everyone got masks, so everyone has masks, and then we didn't think about gowns, and then gowns were in short supply. So I can think of at least one of the health systems in the county that they had staff members driving to other states to pick up gowns from other hospitals to bring back because it was such a significant shortage. Now that has been addressed to some degree, and it's just the unfortunate reality that we're going to have to continue to face as we move forward, because now one of the other unintended consequences of reopening is that I don't think many, at least from a supply perspective, folks thought through, well, when we reopen things, we're now asking people to wear gloves and masks and gowns. And so there are people tapping into the PPE pipeline that historically haven't had to do so. So these are realistic challenges we recognize. Again, we're working to be nimble in terms of securing as much as we can to be able to distribute as much as we can to the homes as well as the other providers. What I encourage you to do is to continue to submit the request to the FEPS team so that we are aware of the needs and we can work with you to distribute as much as we can, but also connect you to some potential other resources that may be able to provide some of those supplies, particularly those that are short in supply. The testing piece, again, As we talked about in the first part of the conversation, we've been working to, again, stand up the mobile testing arm to be able to do just what you mentioned in terms of being able to go to the group homes and other facilities where folks are limited in terms of physical mobility as well as transportation. So our hope and expectation is that we would have multiple teams to be able to go out, whether it's pop-up testing or go visit certain sites to be able to provide those services. And one of the things I will point out that we didn't talk about, and this carries over to this conversation with the state Ngo Teams, is that they actually did visit, for example, a number of assisted living facilities and tested a lot of folks. So even though there were challenges in terms of getting results back, they still tested a lot of people and provided tests to communities and facilities that we otherwise would have had challenges reaching. And so I say all that to say that as we move forward, this group will be a priority in terms of assigning some of the mobile testing teams to make sure that the communities have access to testing, as well as a robust response to make sure they get the results in a timely manner. I think I hit all of your bullet points, but feel free if I missed some to let me know. I'm happy to address.
Just the metrics. I think if we could set up a follow-up call to this, Dr. Gales, I think, you know, there are a lot of folks, and as you heard, there are over 300 different locations. And I know Dr. Brunetto knows it's not everybody hears the same thing or has the same access to information. So I would like to set up a follow-up discussion similar to the zip code specific to this community as well. And we will certainly make sure that it works for your schedule so you can participate. So thank you, Dr. Gales.
No problem.
Chrissy, but Dr. Bridgers will stay here from your team. But Chrissy, please go ahead.
Thank you so much for having me here today. I really appreciate everything that's been said. And I want to tap onto something that Councilman Rice said about the disparities. One of the things about the people that actually are employees are mostly African American. They are mostly from other countries. They are working multiple jobs. They live in congregate homes themselves, not only just with us, but also other places. They're moving around a lot. We do know, no fault of anybody, that's how it was brought into our agency. We were I think we are the first in the county that had the most cases, the earliest cases, I should say. We also were, we had people actually who worked for us who were at that nursing home that was the first case at it. So we had a whole crew there that day helping out. So we were really right on the forefront. We ended up having 22 of the people we support tested positive. We had 2 loss of life. We had 23 of those employees, a loss of life there too. We continue to have that same demographics get exposed. We're working on some lingering cases right now. You know, they are not fully educated on how to prevent this within their home settings. There's a lot of people living with one another. The other thing we ran into that I want to just bring forefront, and I have dealt with this, but I want you to know about this, was the EMS response. We were calling EMS to pick up or transport the people we support. We were turned down. And when I say turned down, we were telling them to take them, and they said they're not sick enough. And they didn't meet the protocol, and they would leave only for us to call back later on to come back. And many of our folks ended up in that hospital with pneumonia, you know, almost being put on vents. It was really troublesome to me. It happened 5 times. By the 5th time, I lost all my patients. I did contact them, and we are working on that because and they shared with me what their protocol is that was given to them to use when they're looking and assessing somebody, which I understand because the hospitals are overwhelmed with cases, so they want only certain people to be transported. What I do want people to understand about our population is they do not present the same way. The 2 gentlemen who we had loss of life did not have a fever, did not cough, did not exhibit any outward signs. What was happening with them was more internal, a taste, probably they lost taste, they were achy, they may have had a headache. They can't communicate that to us. They didn't present sick enough. So therefore, by the time we, by our own instinct, said something's not right, insisted on getting into the hospital, and unfortunately, both of them lost their life. So I can only share also with everyone, please understand that the people in our disabilities community do not present with this virus the same as the general population. Many of them had the gastrointestinal issues. Some of them had vomiting, and some of them just became lethargic and didn't want to eat. And that's what our signs were. And that's what we had to start looking for. So yes, we're taking temperatures daily and all those other good things, but we found out that really wasn't a good litmus test for us because it wasn't following it. And again, the staff people that we employ, they too didn't understand what those signs looked like. And so we've really had to do a lot of education on that piece. And also one more thing that happened to us was that we had no food. We had also opened up 36 homes in Montgomery County, and we couldn't get food. We got turned away from the big box stores and grocery stores. Too much food, you can't have all that. So that became a big thing for us. And so all that's put together, and we were trying to give some food to take home to some of our staff. So all that put together, it is a population of people who work there, who do have that, inequitable treatment. Also, the people we support. We did have the first Ngo team come. It was not really successful, but we were probably the first ones. We had the Ngo team arrived. They did not have PPEs. They asked me, do you have any gowns that we can use? And I said, no. So they had to leave. It took us about 2 weeks. We ended up having over 100 people tested. It was only the people we support. What we really needed tested were all those employees. And of course, there weren't enough tests. Those are the very people who don't have health insurance. They can't get in. They have underlying conditions, all those things we've heard about. So just to kind of say that this is something keeps me up at night is I keep hearing about an insurgence coming our way, another insurgence. I'm most concerned that our congregate living settings are very, very vulnerable to this virus, and the people we support are very vulnerable. And when they get this virus, they crash very fast. It hits them and hits them very quickly, and they get very, very sick fast. So I just want to share that because we don't present like most of the other people in our county. And we do have homes in every one of those high zip code areas. And where we had loss of life were in those high zip code areas. Most of our cases were in the high zip code.
Thank you very much, Chrissy. That's super helpful and sobering on every conceivable level. Just a difficult thing to process. So I'd like now to turn it over to Odile and Dr. Crowell. And Dr. Bridgers is still here with us from Public Health. Odile, could you talk about what your team's response has been, what you have observed, what you have seen, and how specifically the plan is now and moving forward to address the very unique needs of this population? Because as you heard so eloquently, the manner in which we test is different. The symptoms themselves are different because of the inability to communicate. The fact that oftentimes, families are not able to visit their loved ones within these group homes, and the clients themselves don't understand or process why. And it's creating a tremendous emotional distress that is playing itself out into aggressive behavior and a lot of other challenges on top of all the other challenges that our group homes have to address every day. Can you talk a little bit about, from your perspective, what you're seeing, what the plan is now, and what the plan will be moving forward? And I don't know if Dr. Crowell, you want to begin, and then Dr. Brunetto, you speak, or whichever you guys would like to do would be great.
So I'm going to turn this directly over to Dr. Brunetto, but to say that one of the things around this is that it's certainly sobering. The things that Ms. Shaw shared with us has been sobering, and yet just another reminder of how much we've got to deal with at any given moment. But Odile can certainly talk to us about looking forward in terms of what we're doing now and what we're thinking about as we look forward. And I think I would like to come back at the end of that and talk a little bit about what I think we need in the way of partnership from the community.
Great, thank you. Dr. Brunetto.
So good morning. Thank you, everyone, members of the council committee and all of the guests who are presenting today. So first, I want to thank the DD provider community and the direct support staff, the group home counselors, for their absolutely incredible dedication, their endurance, their sacrifice through all of these months and many more weeks to come along. The Interact DD community is extremely strong. The cohesiveness of the nonprofit agency is remarkable, and that has made a big difference in addressing this crisis. So from the very beginning, when the virus got started, I was fortunate to be able to have a weekly communication with the leadership from the Interact DD group. And over time, we were very fortunate that council staff members also joined us. And so we were obviously updating each other about what was happening and the needs in the community. At the very first, these Ngo Teams were going only to nursing homes, and hearing the plea from the DD providers that they needed something similar. I reached out to our state officials and asked if Ngo Teams could also cover the DD provider community, and that was agreed upon. Clearly, it was not very successful, as you heard from our DD providers as well as others who have experienced the Ngo Teams. We were also able to partnership with our colleagues in public health in the area of contact tracing. We reassign some of our A&D nurses, discontinued their regular duties, and I sent them to the public health communicable disease team to focus exclusively on the DD providers. It was a huge learning experience because those nurses had never done communicable disease activities before, and they were able to get some training from a NIH physician named Dr. Shah, and also clearly learn on the job, as many people have done throughout this crisis. The PPE have been provided in some ways through two sides, the DDA state side, as well also as our own local public health emergency team, and it was extremely challenging. I remember the very first time I had a box of club face masks. I had called Rick from Compass and said I have 1,300 face masks. I feel like I have a pot of gold. I just want to give them to you to make sure they get in the right hand. And it has been a struggle ever since with the PPEs. So yes, we have talked about mask fitting. We have talked about where could we have a safe place for people to recover and quarantine in case going back to a group home is not feasible. Those are still in the planning steps. We also, of course, are looking now at this recovery process. And for older adults and persons with developmental and other disabilities, clearly it's pretty hard to think about recovery when we are still very much into the crisis at this moment. I'm so very thankful that many of the DD providers, executive director, have joined the recovery team that just started a week ago. And we have 4 focus areas that were considered priority from our partners in the community. One of them has to do obviously with testing, PPE, and quarantine and contact tracing. The other one has to do with the sustainability of our private community. The providers, both in the DD arena as well as the senior services, such as medical adult daycare, have had very high expenses related to the crisis, and the revenues are not what they ought to be. So the sustainability of our structure is very much at risk. Another area that we are looking at is social isolation. You have heard that obviously people need to stay isolated, and for special populations like older adults as well as persons with disabilities, the social isolation is very, very dangerous. So there is a group that's looking at that, social isolation, access to services, and that includes telemedicine. We have had some challenges with accessing telemedicine in our population, and also volunteerism. As you know, many of our folks with developmental disability gain a lot of skills that lead to jobs through first volunteering. And that has ceased altogether for the past 3 months. And so we're trying to see how we can Zoom bad, obviously remotely. And lastly, there is a fourth group that is looking at communication. I think that was addressed by Rick earlier, that the DD community never stopped providing services. And so we are not reopening. We are just continuing to function in a different way because we have no choice for the safety of all involved. Just also want to point out that the Developmental Disability Administration at this point, for the past 2 weeks, has been able to provide us on a weekly basis with the number of persons with disability that have a positive test, as well as those who have regretfully lost their lives. And also the Developmental Disability Administration is providing the same information for the staff who work in the DD provider's home, those who have been tested positive and those who have passed away. And I think the providers clearly can let you know about some of the work groups that DDA is also forming as far as recovery is concerned. And those work groups just began, and we are very fortunate again that many of our local Montgomery County providers are interested and willing and able to join those work groups. As far as testing is concerned, obviously you just heard from Dr. Gales about what's being planned. So clearly we are going to continue to collaborate with our wonderful colleagues in public health to offer the testing for the DD community. Thank you.
Thank you, Dr. Bonanno. Dr. Carl, did you want to add on to that?
Just a couple of things about this. The work group that Dr. Bonanno is describing is part of the HHS mission area recovery work group, and you were part of that conversation the other day to get a summary of the overall department effort around recovery. I think recovery in the case of many of HHS programs is actually aptly titled rather than reopening, because many of our colleagues and partners never shut down. They just went into protection mode and trying to figure out how to work through this. I think there are two things around this that I want to say. One of them is that, first of all, I'm grateful that the community is engaging in that work group, in that recovery, because I think they represent the subject matter expertise around the operations and the needs of the community that we have to have if we're going to successfully recover. Related to that, I think that there's this issue of guidance. And I know the state, I think a missed opportunity with the state was that we spent a lot of time thinking about nursing homes and guidance and directives around nursing homes, but very little came out of the state around the developmental disability communities and the group homes. And I think that was a gap that should not have happened. But as we think about recovery, I think about it in two ways. One is the guidance around reopening. And I'm saying this across a couple of places, that there is an incredible amount of guidance around here, amount that we know about, and I've learned about from CDC, from Dr. Gales' previous guidances, and from the state around guidance, and from our guild about guidance and protection, about what makes the most sense. The subject matter experts are going to need to think through some of that for the programs that they run and manage and oversee, and think about what makes the most sense from their perspective, given what they know, and think about strategies. And then I think come to public health and to the department and ask, what do you think of this, and get some feedback. Our addictions treatment program, Avery Road Treatment Center, had to shut down for a period of time due to some infections, and stop intakes and reduce their staffing. But as they got ready to reopen, they gave us plans that this is what we think we need to do. And what do you think about that? And we looked at it and said, yeah, this makes good sense. Here's some adjustments. And I think we're going to need that partnership from the DD community as we start to go down this path of recovery. And the other piece of this is that recovery from the department's perspective, from my perspective, is about recovering our business operation, but at the same time getting prepared for what someone referred to maybe the next surge, the next wave of COVID-19, which could come at any time, but hopefully we have some time to get better prepared for it. And that's PPE, and that's the policies that need to get put in place regarding visitation and who can come in and out of the house, as well as how you manage individuals who are how to recognize the signs and symptoms and educate staff and the provider community and on what to look for, and how do we manage cases and for people who are positive. So all of that is part of how we're thinking about this. Part of the work group that Odile is leading is I think our point to make a lot of that happen. I think if there are issues around PPE and that pipeline, I think that's a place to make sure that gets raised. Dr. Stoddard and the folks in DGS are really coordinating on a lot of the PPE process. So if there are gaps that still exist, we need to get those fixed so that we're ahead of the curve as much as we possibly can be as we go through the summer and into the fall.
Thank you, Dr. Crowell. Chrissy, I saw you had your hand up.
Yeah, I just wanted to follow up on one thing that the other thing that we deal with is that many of the people we support have a dual diagnosis of mental illness. And so this isolation has been very difficult, and we've been seeing and worried about some of them. A lot of showing more signs of depression, and trying to get them at least to walk around the neighborhood or something like that. I heard some conversation about that at the beginning. And also that we also run the Inclusive Child Care Center, and we've been shut down because we now rent space inside of a school building. And we have a lot of families of children with either chronic medical conditions and or disabilities who have been homebound, who are really concerned about them. They're not used to having their son or daughter. Some of them have some pretty high intake care needs. And, we're trying to keep them engaged in work, and making sure they're okay. But there is that whole need of that population of families out there with kids with disabilities who have been home and who have not been receiving the usual support. And again, I hate to bring it up again, but to Councilman Rice's point, a lot of people who are lower income, of color, etc., and they have not had the support they need, and we're really worried about them and how their well-being is. So I just want to make sure we don't forget that there's also a population that the Ark Montgomery County, we deal with the children's side of it too. So I go all the way up from 6 weeks to 21, and then also wear the hat of the adult services. So just want to make sure we don't forget about that population and some of those families who are out there trying to make ends meet and very lost and confused and very anxious for us to get things reopened. But to your point, Dr. Crowell, we don't want to open. I know the county may start reopening. We're not looking at that yet. We need to make sure everything is in place and things are safe so that we can do this in a way that's very safe for all the people that we support and our staff. So thank you.
So two things very quickly then to say that I'm going to take this moment to say that the work group that you all are working on with Dr. Brunetto has a counterpart work group that is the Early Child Care and Education work group that is working around how we get child care reopened. So I'm going to ask Dr. Brunetto to make sure that she touches base with her counterpart, Barbara Andrews, to make sure that this is an issue that gets pulled into that conversation as well, so that we don't lose that thread. We are working and talking with the schools about how we can reopen childcare in school-based settings as well. So that should take care of it, but I want to make sure that the group you're talking about specifically doesn't get lost.
Yes, this is Odile. Yes, I want to confirm that connection has been made. I informed Chrissy that there is a group on childcare, and she's connected with it now. Thank you.
Oh, why do I bother?
Okay. Councilmember Rice.
Yeah, so I just wanted to address that piece because, and thank you very much, Chrissy, for bringing this up because it's incredibly important. That's been part of our conversation with Dr. Smith. Certainly when I think about some of the schools like Longview School and others who deal with intensive cases and really provide that support for parents pretty much 8 to 5 every single day. And now that's not there. And it's not even just about the sort of respite that our parents need, but it also is about furthering along their skills, their education, their social inclusion. All those kinds of things are incredibly important as well. And we've lost that for a large number of our students with differing abilities and those who have some either mental or physical or health challenges. And so from that perspective, we know that that's lost. That's something that we talked about on Monday. So we're going to be coming back to that, just so you know, but thank you for lifting and elevating that because, and you're right, when I looked at some of those faces on Monday of our graduating class and some of those children that I know personally from Longview who are now graduating out of those programs, I thought about them and said, so what have they been doing over the past, 4 or 5 months because realistically, they haven't been able to access the level of care nor support that is necessary for them to continue to thrive. So thank you for bringing that up. That's really, really important.
So I'm going to just make some closing comments here, and then just as we did specific to our zip code work, suggest either we join the next work group meeting around this issue or that we have a specific follow-up because obviously, as has been underscored and articulated so beautifully, there are very unique needs to this population. And so there has to be a very comprehensive approach that addresses those specific needs. And I will say this, I know that all of us have been extraordinarily frustrated since the beginning of this pandemic. And many of our providers have felt, just as the county has felt on its own because of the lack of federal response and challenges with the state, our providers have very much felt on their own too. And you heard some of that frustration from Impact, you're hearing it now. And I think the county's gonna have to work on repairing some of those relationships and building back some of the trust that we had spent so many years trying to establish because you have both the provider community and the families who are understandably very frustrated and feeling as though more could have, should have been done, not really understanding all the layers of complexity, but underscoring why it's so important that from this moment moving forward, we get this right. And we look forward to the written responses from HHS, and we will work collaboratively with the work group. And I will say this, all of my colleagues and I have said repeatedly throughout this entire pandemic that where there are areas that we need additional resources to specifically address the unique needs related to public health and some of those systemic issues, to not hold back because we have to work collaboratively to address those issues. And Chrissy, looks like you want to say one more comment before we wrap up. No, you're good. Okay, awesome. So thank you all very much. That was a robust and productive discussion that will continue. And we wanted to make sure these two specific areas were highlighted because the nursing homes have received a lot of attention, as they should. But these are two areas that have not received as much attention. So thank you very much. Linda, was there anything that we missed that you wanted to make sure we covered in this segment?
No, I think you've covered it. I think highlighting the really unique needs are important, especially in process, because just simple things like making sure you have your authorizations in the DD group homes done ahead of time, because those residents can't necessarily just grant authorization when the team comes in. So I just think highlighting all those unique needs and our need to create process around them, both in the high impact zip codes and also in the DD group homes.
Thank you. We're now going to move on to the second item on our agenda, which is a follow-up discussion during the budget process, specifically with regards to the developmental disability supplement. All of my colleagues acknowledge support for, we established the framework of a continuity of service budget to address the unique challenges of not exactly knowing the financial picture, of the process of not being able to meet as committees, and of trying to ensure some semblance of structure to an already difficult process, even on a good day during the budget process. But we did say very clearly we would revisit this because we know what a high priority it is. And so that's why we are here. So Linda, I'd like to turn it over to you to walk us through this packet and specifically what we need to do and what action we need to take.
So this is a very narrow revisit. So I would just like to say when we did the original continuity of service budget, there was an item in the packet that acknowledged that we have 6 more organizations, which we are always glad to have more partner organizations to serve the developmentally disabled, but we have 6 new organizations that were not in FY20 that are eligible and in FY21. And so additional funding above the FY20 level is really needed to even the playing field at a continuity of services level. DHHS has gotten updated information from the state on revenues received, which is how we've looked at the DD supplement. And so I'm recommending that the committee ask the council to approve a special appropriation of $371,761 just to address these additional organizations. And then also I did want to say this is not the bigger issue, which the committee and council have also asked, which is continued work on the overall structure of the entire, DD supplement and what that funding might be, because this is not the piece about any general increase to the DD supplement or any targeted increase. It's just to adjust the total amount to provide really a real continuity of services budget that accounts for all the eligible organizations.
Thank you, Linda. That's super helpful. So could I get a motion? I support the appropriation. Let me just say that up front. Don't want to bury the lead because this is, we've added the 6 organizations and this is continuity of service, but based on the literal definition,
That's right.
we, that fell into one of those gray areas that we discussed, but to be consistent, wanted to defer back to it. So I see a motion.
So moved.
From Member Rice, second from Councilmember Glass. All those in favor of advancing the special appropriation, please raise your hand. And that is unanimous. And we will revisit the broader discussion at a later time. But this one has, all of it is urgent, but this one in particular is to make sure these other organizations are eligible. So thank you, Ms. McMillan. Was there anything else regarding that item on the packet?
Nope, that's it. We'll get it prepared for introduction.
Thank you.
Thanks.
All right, so this moves us on to the third item on the agenda, which is a follow-up to our discussion earlier this week regarding food security. And I know many of us have been tackling a number of different angles of the food security issue. I want to thank Councilmember Rice for very early on during the pandemic spearheading an effort to help address some of the immediate needs that we needed and that he and his team saw early on, and that was a down payment based on what we heard earlier this week is going to be necessary moving forward. And so there were several items that I wanted to follow up on, and I'm sure my colleagues have other items that they wanted to follow up on as well. One of the items that I would like to follow up on is specifically with regards to volunteers, which are going to be a critical component of this strategy moving forward. And I know there were times, understandably, because of everything going on, that it was difficult to recruit volunteers in the midst of the pandemic. And as we've heard in other briefings, there is an anticipation of an additional surge. So I don't know if Heather or who's in the best position to talk about some of the plans moving forward, specifically on ensuring there is volunteer capacity to meet the ongoing needs. And are there some policy or barrier issues that you think we could address to help eliminate some of the barriers to volunteers being able to access programs?
Hi, Councilmember Albornoz. My name is Maggie Davis. I work with the Food Security Task Force from the Office of Emergency Management and Homeland Security. To address your question about volunteers, that is something that we have been working closely on with the county's volunteer and donation management plan. And so our communities organized in aid of disaster has been set up, and we've been engaging with a robust volunteer force. And what we found is that we have a strong volunteer base available, and we've engaged volunteers with our Medical Reserve Corps to assist with this effort, as well as another number of other groups, and have been working closely with the Volunteer Center for the county. So at this point, I think we have a strong plan to engage and leverage volunteers as they're needed. That is to say, we have a plan moving forward, but as with everything in this pandemic, there are, changing circumstances at all points in time. So I think we've done as best as we can to identify groups of volunteers that can help backfill volunteer needs with our food assistance providers.
And if I may add to that,
please, Netta.
Sure. Thank you for having us again. We are operating with volunteers at many different levels. So we have CERT volunteers and MRC volunteers who are county volunteers who have been supporting the effort tirelessly. So that's the community emergency response teams and the medical reserve corps that are a state asset, but are used at the county level. So they both, I'm going back to something that you said on Tuesday. You said if there's anything we can help do to support them do a better job. The Medical Reserve Corps is at the state level. But for example, if we can tell them that we are reimbursing gas for them, right? Then maybe we can help. They've been doing a great job in offering to drive. If it's drive food around for us or drive for delivery or really anything we've needed, they've offered to be drivers, and they're even allowed, actually, if they sign a waiver, they can drive county vehicles. So that can be leveraged and helpful. But if they need to drive their own vehicles, if we could provide them with more assistance financially to help them do that, that would definitely be helpful. But for the most part, like Maggie said, we've seen more volunteers that we know what to do with, which has been wonderful. And I think the introduction of the SSL hours for volunteer hours has also been a great leap and move ahead to allow more teenagers to enter the response volunteer force.
That's great to hear. Heather or Jackie, did you want to add anything to that? Okay, great. Councilmember Rice has his hands up, so go ahead, Councilmember Rice.
Well, I just wanted to start off, Mr. Chair, and thank you very much, with just a brief kind of statement about where I hope that we're headed in this whole thing, because I've had a number of conversations with a number of folks who are here on the panel, so it's really good to see everyone, and thank you everyone, from Capillary Food Bank to MANA to our Food Council to many of our nonprofits, Nourish Now and Care and Kind, and all the folks who are out there who are doing the great work every single day, because it matters so much. And you've heard me from the very beginning, back in the end of March, talking about the need that was going to be out there. The key in this whole thing is that I think that a lot of people are underestimating the impact that will continue to ripple through our communities, and one in which we're just at the forefront. Keep in mind, we put a stay on evictions, and there will be people who will lose their homes. I promise you, we know it. We all know it. And so that means even more instability and food insecurity as a result, as well as housing instability and housing insecurity. All the wave is just, we've just seen the uptick. But the actual true crest of that wave and what it's going to do as we're in the midst of a recession. And folks, we know this is going to be a long-standing thing. This isn't going to be, we don't have recessions that turn off like that. And even though folks are talking about the V, this is a V recession and all that. Look, at the end of the day, the recession means that folks are going to lose their livelihoods, right? We know that that's exactly what happens. And so that means that there will be more people who will be stood up. I actually have a really good friend, who is a high-level executive who just was let go 2 days ago. Just found out about it, was shocked. I'm just like, and I don't know where this, because this guy made a lot of money, and so his family and all of the things that they have in place are built on that. And so with that not coming in, what is his family going to do? I have no idea. And I'm just like, I'm shocked. And I'm sure he'll land somewhere. But no one is immune is what my message is about what is now happening. And so I want to make sure that folks understand just why this is so important, that we have to do this, and we have to build a sustainable structure that's going to make sure it carries us for a long period of time, because this will be something that continues to impact us for a while. And that's absent any kind of, keep in mind, I haven't mentioned anything about, we just got through talking with Dr. Kroll and Dr. Gales. This doesn't even consider about an additional spike, right? Now they're talking about a summer spike in addition to a fall spike. Those are things that just throw us, and I'm not trying to be a fatalist here, but I'm just saying at the end of the day, it's like we have to be prepared for this stuff. And so that's why, for me, I think we have to get aggressive. We have to get very aggressive in terms of our support and our infrastructure that's there, working with our farmers as well as our food providers to make sure that we develop a very strong system that doesn't allow for these things that we know are coming to break those chains, right? And so from that perspective, it really is one where I just wanted to put that out there as to the impetus for why at the very beginning, we as a council were united in terms of our support. And while we still are united in terms of our support of making sure that we can provide you guys with all that you need to keep this going. It's just incredibly important. So thank you for your indulgence, Mr. Chair. I just wanted to make sure that I put that out there because that's why this is so important to us. So.
Couldn't agree more. Councilmember Glass, you wanted to make some opening comments as well.
Yeah, I mean, we had a really in-depth conversation on Tuesday, and I again, just want to thank everybody for their work and reiterate the headline from that conversation that here in Montgomery County, we've provided 2.8 million meals since the start of the COVID-19 pandemic. And my hat's off to all of you, and to everybody in county government, outside of county government that's providing support services, all the volunteers, everybody who recognizes the need. And most startling is that number, because while we've been able to provide all of those meals, we have to provide all of those meals. And as we know, the demand is greater than what we've been able to provide. And so I look forward to this conversation, to figuring out how we can even do a better job within our processes and procedures and collaboration to make more with what resources we have. So thank you, Mr. Chair, for scheduling this discussion.
Thank you, Councilmember Glass. Ms. Breskin, you had, everybody did such a great job on Tuesday, but I think I wanted to hear a little bit more from the Food Council's perspective on what you see moving forward. The task force has been incredibly helpful, but would love from the Food Council's perspective, just some general thoughts to add to this discussion.
Yeah, thank you so much, Mr. Chair and Council Members Glass and Rice, and to the entire Council for the opportunity to highlight this really critical work in our community, and the opportunity as well to continue the conversation that we had on Tuesday, which I know is a real focus of the Council's priorities, and as it should be. So my name is Heather Breskin, for the record, the Executive Director of the Montgomery County Food Council. As we previously discussed, the county's investment for years in food security infrastructure, systems, and network building allowed us to mobilize quickly for a coordinated response. And I have the opportunity in my role to engage regularly with partners throughout the region and throughout the DMV. And Montgomery County really has been held up as a model, and the initiatives that we have put in place before COVID and in the current response efforts are being replicated in other places through the work that we're doing here. So I think it's really important to note that. And the work that we've done in the past few years with Council's priority in investing funding in this work and referral resources, network building, and relationships across sectors, agencies, and throughout the food system really did strengthen that initial response. That said, it's really hard to adequately capture how complex, vast, and dynamic the food security landscape in our county currently is right now. So we have a 50% increase in providers with regular distributions, and that doesn't even reflect the organizations and businesses that are doing one-time pop-up distributions. We have 3 to 5 times the normal demand for services by our for our food assistance providers, and we have shifting resources and programs at all levels of government. And this is all during a pandemic that's massively impacted distribution strategies as well as outreach efforts. I wanted to give just one example of the recent grantees from the county grant process. Of those organizations that were awarded funding, 68% of them before this grant award didn't currently receive funding for food from the county. So that shows just a dramatic increase in the organizations that were coming into the fold for this work. And 40% of those organizations that were funded are faith-based organizations. And Councilmember Albornoz, I know that you had asked about faith-based organizations specifically, and that percentage of the new grantees reflects, it holds close to the percentages prior prior to the pandemic of those that were from our faith communities. So it's also difficult to convey how overwhelmingly impressive this community response has been in supporting residents, and the tireless work, creativity, and that entrepreneurial spirit that's always been the hallmark of Montgomery County's residents and organizations. I shared a letter with all the county council members on Tuesday following our session that was highlighting our organizational priorities in that food system response. And I know that we have limited time together, so I don't want to reiterate all of those points, but I did want to pick out just a few to share with everybody today. That it's critical that we continue to build an intentional, locally driven hub network, but in doing so, we really need to carefully both engage and build the capacity of smaller organizations, grassroots community-based organizations with deep ties and hard to reach populations in this food security work, while also building on the strengths of our established provider organizations that have significant experience and infrastructure. And we can do both, but we'll need to do it thoughtfully and strategically, drawing on the unique resources and strengths of each of these organizations. It's also critically important to engage community voices directly to inform this work and increase outreach efforts with a focus on cultural competency. We need to make investments not only with an eye on cost efficiency and providing immediate resources, but we also need to focus on long-term resiliency and income sufficiency in our food system. And it's critical that economic development and opportunity are directly connected to food security, and we can't distinguish between the two in the investments that are made in this work. We need to maximize federal programs and resources like SNAP, and also focus on data collection and analysis. And our county has tremendous resources and expertise in that work, and we need to do whatever we can to connect that specifically to this food response. I don't want to take too much more time, but I wanted to just also reflect on some of the Food Council's efforts specifically over the past 3 months, recognizing that while we have a small staff of just 4 people, these accomplishments are possible due to the collaboration with hundreds of residents and organizations. So we always use the collective we when we talk about the Food Council, because it's many, many people and organizations that make this all possible. And that includes from our nonprofit sector businesses, as well as our government agency partners. So we've been conducting outreach to all of the organizations that applied to the grant process. So that was 105 organizations total, both those that were funded and not funded, to connect them to funding resources like community foundation grant programs, smaller foundation grant opportunities, giving them individualized feedback on their applications to provide support to them, and also hopefully connect them to future funding opportunities, connecting them to food resources like the produce boxes, as well as bulk purchasing opportunities such as those through the Capital Area Food Bank and Manna Food Center, technical assistance through Nonprofit Montgomery, as well as data collection and grant requirements. The task force is collecting each week data on services from providers, but that is a challenge for a lot of organizations to be able to invest the time to collect that data, as well as new strategies, especially for those that are doing food assistance for the first time. And so hoping to connect those dots, just like you said, Councilmember Rice, to better capture the breadth and the scope of services that are happening, as well as the trends for how those numbers are changing over time. And so the more data we have, the better we can understand the scale of the need. We're also fostering partnerships in specific with a lot of our hubs that are emerging throughout the county. The grant applications provided zip code data on where these providers hope to connect with residents. And so that enables us to connect them with the hubs that are in those communities. And what's been really exciting is seeing the hubs working together to identify which geographic locations they're supporting, so that there's not an overlap in services. And so I want to make sure you know that that's happening. Also working closely with our regional service center directors and their work supporting local communities. Connecting these providers with transportation, PPE, volunteers, storage space. We've been establishing a list of contacts for retailers and restaurants that feature culturally appropriate food to facilitate those purchases and connect the providers who already have established relationships with those businesses to the organizations that are seeking to establish those partnerships. We're regularly connecting these providers to our weekly calls, and also providing additional resource trainings based on a survey that we're currently administering with all of the grantees. So that is, we just brought on a graduate fellow who's working full-time on providing support to our food assistance providers and those grantees. So I think there's a lot of, and the hands-on support is really what these groups need. We're doing tons of convening. Councilmember Rice, I know you're with us for our weekly call, and all of our council members have joined us for those gatherings. Regularly, 120 people, over 250 unique individuals joining in a weekly community discussion, identifying service gaps, barriers to services. It gives us a chance to poll our providers every week on the trends that they're seeing within their programs. Our community advisory board has been involved in the grant review process and developing the application for that grant, giving us feedback on resident surveys that will be administered. Also a lot of work around the pop-ups. Gathering information and communicating out to a variety of stakeholders, all of the different pop-ups that are happening. And it's a quickly shifting landscape, but we just sent out an email yesterday with a list of, I think, 8 different pop-ups that are happening throughout the county. And if there's broader awareness of where they are and where they're located and what their goals are, we can maximize those opportunities. And we're having regular discussions around how we can effectively serve walk-up participants to car-based distributions. How can we use those pop-ups as opportunities to connect participants to other more regular resources to hopefully avoid wait times or the possibility that they'd be turned away without food, and backing up supplies to avoid running out of products during those distributions. There's lots more other things that are happening. I don't want to take too much time, but I just want to note around communication. Our website has seen a 10-fold increase in use, and we've recently implemented direct translation into 5 languages on our website. We've created a referral flow chart and trained over 400 county staff and community partners on food assistance resources and referral strategies. Our resource map is updated daily. We just had a volunteer call all 105 organizations to make sure all the information is correct and accurate. And because we want to make sure that people are being referred to organizations that are still operating. That changes quickly. And also working on a resident survey to directly get community input on the experience of food insecurity in Montgomery County during COVID-19. So that's and just a lot of things around SNAP outreach as well, but I'm sure we'll get to that later.
Yeah. So that's a lot to process. Thank you so much, Heather. There's a lot of, we know, really incredible work going on. And I'm particularly interested in those survey results and how we're administering that. So I'd love to see them once they're made available. And I want to thank Vivian, who put out a few bullet points of items that we hadn't had a chance to expand upon in our discussion on Tuesday. One of them is MCPS, which of course crosses over into our Education and Culture Committee. And I want to defer to Councilmember Rice if you have any specific questions with regards to, because I know there was a question about the waiver this summer and what the plan is moving forward. I'll just make one point that was pointed out to me, that there was some frustration expressed by families who have to go every day, had to go every day to access, some of the food during lunchtime. And I know, having 4 kids under the age of 12, how hard it is to get everybody out the door and to have to do that every day. And then to have to do that when you're trying to socially distance and not allow kids to go to the playground, which they can see but want to get to, it's just hard. So I think the recommendation was, would it be possible to consolidate some of those meals so that they're receiving 2 or 3 or 4 or even 5 days worth, if that's even feasible or in any way part of the plans this summer. But I'll defer to my incredible colleague and chair of our Education and Culture Committee to set the scene and talk a little bit more specifically about summer nutrition and questions he may have.
So, Councilmember Albanos, the reason why I love you is because you're thinking outside of the box all the time. And that's one of the things that really is truly important, is to make it easier for folks to access the nutritional meals that we know that are so important to them, especially throughout these summer months. And so one of my biggest concerns has been about us reducing the number of sites because, again, understanding even are starting to open up some of our transportation modality, whether it's through ride-on, the reality is it's still incredibly difficult And we know we have to go to a school to go and get meals for folks on a daily basis or even an every other day basis. We know the challenges that is navigating this county. We've talked about that in terms of our transportation. That's when our transportation was running at full 100% capacity. We still had lack of access for a lot of folks. And so from that perspective, we're going to have to continue to step up and do more. So I'm gonna couple that with what Councilmember Albornoz was saying in terms of when it comes to what we do on Wednesday, because we have the 2 days that we distribute on Wednesday that carries them over to Friday. That's why we don't have food distribution on Thursday. Would it be possible to do a Monday, Tuesday, Wednesday, Thursday, and then Friday is the weekend ones, but 3 distribution times a week? So that's one question that addresses what Councilmember Albornoz was talking about. But then also about the number of sites. And if we can commit to ensuring that we don't reduce the number of sites, understanding that it's going to be even harder for folks to get to these other sites. The reason why we stood them up is because we knew that they were convenient to folks in the neighborhood. So we'll start there.
So is this directed towards me?
Yes, Jeannie. Sorry.
All right. Hi, I'm Jeannie Dawson. I'm the director of the Department of Materials Management. I think there's a delay. Hang on a second. I'm not sure why there's a delay.
There's a delay in the video, but we can hear your voice fine.
Okay, perfect. All right. Well, I'm going to keep speaking then. All right, so I am the Director of Materials Management for Montgomery County Public Schools. And essentially, we are running under a summer food service program. Just to give you a quick background, and what that means is it's a USDA federally funded program, which is directed at the state level through us as a county school system. And really it's about nutritious meals and it's designed to provide meals at no cost for students that are 18 years old or younger or in our school system. And that's what we've been running under as soon as we began this COVID process from March 16th on, which the following things apply. So I know you wanted to know about the waivers and how are we taking that into the summer. So we have waivers through June 30th, and we have 6 waivers at that point. What we were concerned about were waivers from July 1st on, which allows us to operate under this summer food service program because that's when it officially begins, is when school ends, June 16th. So we are covered through the 30th. The waivers actually are the parent and guardian pickup. So it allows us to pick up, parents to just come pick up meals. You don't have to have your student be there at the site. The second waiver is a mealtime flexibility waiver, which allows us to serve multiple meals at one time, because normally under a school year, you have to separate breakfast a few hours from lunch. And then our third waiver is the non-congregate feeding, which allows us to eat at home. So our students do not have to eat at school, right? So we need a waiver for that. The other waiver that we are excited about, because we just found out yesterday afternoon, is that the area eligibility waiver, which we began this whole process at 50%, then it was reduced to 0%, which allows us to feed all students anywhere throughout the county. So now, as of yesterday afternoon, they have not only, we have that extended through the 30th of June, but now they've extended these waivers that I've just mentioned through August 31st. And in particular, that waiver of area eligibility, which allows us to maintain our sites and keep them open. The other waiver that just came through was also the meal pattern flexibility, which allows us, and we as a district, other districts have chosen to have other components where they didn't necessarily carry them out in every meal, but we choose to carry every component of the meal out. The only thing that we put in a waiver for was dairy, because our dairy is delivered on a daily basis. So just in case something was late, that we would be able to manage that. And then the waiver that we have until June 30th, which is our supper waiver. That's through a separate CACFP, which is the it's the care for child adult care food program, and that allows us to serve supper, because normally under the current regulations of summer food service program, you serve 2 meals. It's either breakfast and lunch or breakfast and supper. And currently that breakfast, lunch, and supper continues through June 30th. But right now, as of July 1, that is the only waiver that we do not have to continue. And that means that we would continue serving breakfast and lunch, but we would not serve breakfast, lunch, and supper. So that would be the difference. I'm trying to think of the other aspects. So in terms of days, you talked about the idea of, reducing the number of days. Well, that is why we went to a Thursday release. And the other thing that you want to consider for us is, because we have, over 165,000 students, soon to be 167,000, I believe. We just, in the last 2 days, I told you we had 2,600,000 since I saw you last. Now we're up to 2,800,033,165. So we served on Wednesday with our double meals, 1,410. The volume to double up meals for us requires an enormous Herculean effort on all of our staff's part. We have over 350 people currently working in schools. Schools end on Monday. So now we move to a different structure, but we still need all of our people to work. And we have that in place. So that's not a concern, but the concern is being able to social distance, make the meals, to be able to get them out at the volume and the rate. And we see things increasing, not decreasing. One of the things I'll tell you that we talked about was, if we reduce to 2 meals a day, is it possible for us then to go to, like a Monday, Wednesday, Friday distribution? So that could be a possibility. If we maintain a 3 meal a day, that combination, it's just an enormous amount. So we're dealing with the volume, and the ability to maintain that volume requires quite a bit in terms of making meals, getting the product in, getting the product out quickly. So that, those are the things that we struggle with. But we also recognize that, we don't want to bring parents out as much as we have to. So we're still, still a work in progress right now. But currently, through the 30th, we have 3 meals a day.
Okay. Well, I appreciate that answer. I really, really do. And appreciate all the great work of the Division of Food and Nutrition Services. You guys have been amazing. I've been out there on the front lines and seen it many times, including your smiling face while social distancing, of course. But it is one in which it really is a Herculean effort. We really do appreciate it. And so, we can aspire to do some things, and logistically they may not be able to happen, and we certainly understand that, and still respect the great amount of work that's going in to standing this up. This was not easy, and there are a lot of other jurisdictions who struggled with it in the beginning, and we were one of the ones who came out of this right on the top of the game. So I really want to say thank you. Let me just pivot to Manna, because Jackie, what I do want to do is make sure when it comes to, and then I'll ask the same question. I'm not sure if Judy's on from Women Who Care Ministries as well, but I just want to ensure that throughout the summer, that what we have going on right now will continue with the weekend backpack program, and if you have the funding necessary to make sure that continues. And then I have a question. Mr. Chair, I'm going to turn it back to you, but I'm going to pivot into capital area food bank and some of the other things that we're looking at transitioning to, which is more general HHS question.
Sounds good.
Yeah, thank you, Mr. Rice. Glad to be with you guys again. And simple answer is yes, we plan to continue with this great partnership with MCPS, and we were all relieved about the waiver yesterday afternoon and people doing little jigs around the office. So that's great news. We have, and I believe Maggie Davis is on the line. We have, we believe certainty that of the emergency monies that are being released out of the CARES Act, 75,000 will be coming to us so that we can obtain shelf-stable items for that distribution. So we are grateful for that, and we feel like we're in a pretty good position to continue on through the summer.
Excellent. Well, thank you. And so the last question is to turn to then our capital area food bank, one of our largest providers here in the Washington metropolitan region. The question is, are you able to then provide the food that's necessary to stand up? Because I know that the draw on you is coming from multiple directions, not only including the largest jurisdiction in the state of Maryland, but also everybody in this entire region is asking all at the same time. You've got a school system that's utilizing you and others, providers for some of the things. So how are you when it comes to being able to stand up something that is, I'm sure, exponential above where you're used to providing, and how is that going?
Sure. Well, thank you for acknowledging all of those challenges during this time. My name is Susan Topping. I'm the Senior Director of Food Policy and Impact with the Capital Area Food Bank. My colleague Adam LaRose and I are joining today. Our Executive Director, Radha Muthaya, had to step off. So apologies that you'll have to put up with us. So the Capital Area Food Bank really has been working hand in hand with our partners. And so, as you know, and was mentioned earlier this week, at the same time that half of our network has decreased throughout the region of 450 partners that we traditionally take pride in being the blood in the veins for their work throughout this area, approximately half, less so in Montgomery County. About 2/3 of our network still exists and is functioning, and that's been a changing target and something I think everyone can take pride in. Early on, at the beginning of March, we had half of Montgomery County of our partners, of the 42 that exist, half of them were closed, and more continue to reopen over this period of time. And so at the same time, we're dealing with 75% reduction in the donated food that is coming to us. And that is, our great friends in the retail business and throughout the system, the food system, they've seen delays, they've met their own hardships. And of course, that has an impact on organizations like ourselves, MANA, and so many others. And so those are larger supply chain issues that we are all struggling with. However, our network, as it continues to get stronger, we are finding different ways to meeting the need. And so that really, I think that was really seen in the last 3 months when we were able to distribute 1.4 million pounds of food in Montgomery County alone, with half of our network functioning. And so in many cases, we're doubling our production with half of what is available to be able to meet that need. And we do that in a variety of different ways. Not only are we depending on our network, but we partner with phenomenal institutions like MCPS that gets the job done and creates those types of hubs. So not only is a family coming and getting prepared meals, but they can also get shelf-stable foods and fresh produce and some instances milk that they can take home and prepare for their family. So hopefully that gives them a little stretch in their budget so they can continue to make those meals, not during the week, over the weekend. And so those types of partnerships are invaluable to us. Additionally, we're looking at how
In the longer term, we'll continue to meet that need. And that is relying on some of the strong partnerships we have in Montgomery County and elsewhere to be able to expand our operational capacity with warehouse space. It has to do with expanding our operations team. We are in the process of hiring our second full-time individual. It's expanding our fleet in this area. And so all of those pieces are a part of how we are working in concert with our network to meet this need. Additionally, looking at some of those special partnerships, MCPS, as well as Casa de Maryland, not traditionally a food distribution site, but because they know are critical in getting food out, we were able to partner with them. And they were able to find different ways to get food directly, not just in a distribution, but actually take it to individuals' homes. And so through a variety of working with our existing partner system, working with our network, expanding to some of our, what we call our temporary partnerships, also giving greater flexibility to what we call some of our hub sites that have the storage capacity, as well as the overall resources to be able to get larger scale amounts of food out into the community. That's how we're looking to continue to get it done.
Mr. Chair, I yield back to you, sir.
Thank you, Councilmember Rice. Councilmember Glass.
Thank you, Mr. Chair. I know that we've all been here for a little while talking about all the incredible work that's going on, so I'll make my questions brief but specific. We've all been involved in the number of efforts, and again, the efforts speak for themselves by the sheer volume and demand that you all have been in the community providing food for those who need. Logistically, I know that a lot of people have been calling 311 to request information or services, and so I'm curious how that relationship is going. Just basically a functionality question. When people call 311, where does that go to any of your agencies or departments or organizations? And I don't know who to direct the question to because I don't know who 311 would contact.
I think representatives from the Food Task Force can field that question.
Yes, I'm not sure if Netta Squires is able to unmute her phone because she's had some more insight on this than I have, but the Food Security Task Force with partners in HHS stood up a food call center line that I believe started the first week of June. And so when residents call 311, 311's able to connect them directly to a group of county staff that can serve as navigators through food resources. And I know the staff to staff that line. We've been prioritizing staff that have multi-language capabilities. They also still have access to the language line as 311 would as well. I would also like to highlight one thing we've known is that there has been an increase of Spanish speakers calling 311 for food access. And when we looked into the data, we think that was a result of some good outreach efforts, particularly to some of those harder to reach communities to connect them with resources. So we do know that residents have been calling 311 and have been provided some navigation to existing food resources.
Excellent. Thank you for that. And thank you for sharing that priority is placed on multilingual speakers or understanding the importance of that. So thank you. And with the resources that we have, I'm curious about the prioritization of them from those organizations that are helping distribute fresh food, those that might be distributing cooked meals, and those that are distributing more shelf-stable meals. How do you decide what resources to share, or if there's limited supplies of any of them, particularly I would think fresh food or cooked meals? What is the process for sharing those with the nonprofit providers and the frontline personnel, essentially?
I'm happy to answer part of that. This is not to Squires. So for the produce, for example, the USDA produce boxes, it is really, if you ask for it, you will get it. So any organization that has come forth and asked, and we're trying to put the word out, and but pretty much if anything that you ask for, in terms of other supplies, for example, like hand sanitizer and stuff like that, it's really we've created a weekly snapshot that we put out every week through the Food Security Task Force, and providers are able to identify any needs they have, any challenges they have, so they report on what they've distributed, for example, the volunteer hours they've done that week, and then any challenges. And so if they are experiencing a shortage in a type of food, they have self-identified, and then we will contact them and try to connect them with the correct resources. And just generally, that's kind of been the approach, as we hear by providers that they have some shortage of whether it is food or a specific kind of food, or resources or volunteers. We've just connected them with the resources they need.
And so I appreciate that. And so just diving a little deeper into it, is there a matrix or any criteria regarding what organizations might request versus the communities or areas? And communities and areas are not necessarily the same terminology or have the same definition, but the people that they're serving in the locations of those communities, to see if there are other organizations serving them, to see what other resources they have. And I ask because as more and more organizations are asking for support, clearly it comes back to us that we need to increase more funding to be able to procure or provide support for that. But I'm just curious if internally there's a matrix to make sure there's no necessarily overlap, redundancy of effort. And then I guess also to make sure that when organizations are participating and they're requesting items, that when the demand for them continues to increase, theirs might not lessen so that it goes to another place.
Sure, and actually we have Patrick Campbell here, who is our operations lead, and he would be best suited to answer that question.
Operations lead is the title that I'm looking for. So yes,
perfect.
Thank you, Patrick.
Yep. So Patrick Campbell, when this isn't going on, I work for the Department of Health and Human Services, and so right now I'm basically full-time assigned to the Food Security Task Force. Maybe first to go with the first part in just terms of the types of food and how we get that food out is, in terms of the produce boxes, we're soon going to have a 2-week drop in our produce boxes because of a kind of a mistake with one of our USDA distributors. So for about a 2-week period, we'll have about a 14,000 drop in produce boxes. So unless we can get funding for that, there will be a drop. And so for about 2 weeks, we will not be able to add any additional organizations into our food produce program.
And so let me ask for some perspective. You said 1,400?
14,000.
14,000. How many do we normally get?
So right now, typically on a week, we've grown the program to 26 to 28,000 a week.
Oh, so that's a 50% reduction.
Yep. So the issue came to us very recently. So we have raised the issue and we worked with the producer. So basically the way the USDA program, they make so many available to each state. Some of our boxes got distributed to a different county. So the USDA program can't just magically give us, boxes above and beyond what they're allocated. So we have worked with the vendor to potentially get those boxes at lower cost, but basically it hit us Monday night and we're trying to work to a solution. So we have looked at what it would cost to replace those boxes for a 2-week period. Once the 2-week period is up, then our USDA provider will be able to get us the full amount that we normally need.
And so, okay, so I appreciate you sharing that information that for the next 2 weeks, we'll have a 50% reduction in the fresh produce boxes. Are our nonprofit providers aware of that? And what is the plan to mitigate it?
Absolutely. So we have reached out to basically my team's reached out to all the people we currently provide the boxes, and we've cut back everywhere we can, trying to leave everybody with some. But unfortunately, with a drop this quick and with the way the turnaround happens, there is no good way to, truly deal with this. We actually increased the amount of boxes we were doing about 2 weeks ago when we had a number of sites essentially, overrun with the amount of boxes that were needed. and then to have like kind of a late notice from the provider that they can't get those boxes, you know, it's going to be a shock. So no matter what we do, it's going to be a shock because the produce boxes have been able to fill in a gap as some of our typical staples have been unavailable. You know, for example, like when they couldn't get certain canned goods, all of a sudden we were able to replace it with about a 20 to 23 pound box of vegetables and fruit. So we have notified them, we trimmed where we have, and currently we're not adding anybody until we can alleviate that.
Okay, I appreciate that. And just last question I'll have, I think we touched on this earlier this week on Tuesday's council session, but diving a little deeper here regarding the transportation problems, and it's been alluded to in this conversation. What are the plans moving forward to get the meals, to get access to individuals who need it? And I'll share that I was at a location about 2 weeks ago in Wheaton, and just trying to figure out the people who were driving in versus the people who were walking up, because who knows what their own transportation access is. But clearly being in the community where people could walk was critically important. You know, secondarily, we had to help some who couldn't carry a 23-pound box of produce, but they had to walk up and get that. So moving forward, how are we trying to help out with that transportation lag?
Well, I'd say it kind of comes down to probably a few different parts. One is, you know, we worked with our CERT team to provide delivery at our Gaithersburg hub. And then we're also going to start using more and more of our medical reserve corps to assist some of our hub sites with delivery. But one of the great challenges is, I think you might be referring to the Highland Elementary. You know, the dream is when you get into an elementary school, it's great because it's so perfectly situated in the community, but then it creates other traffic problems because those elementary school locations aren't designed for high volumes of traffic. And that's what we typically find. The dream location, you know, often creates all kinds of other problems. So working with MCPS, you know, we brought some school buses into some of the apartment complexes. So they actually take a school bus, bring it to an apartment complex, do a pickup that way. So we eliminate some of that. And you know, that's been a unique way to introduce, because one, we're also putting our drivers back to work. We're using school buses.
I think that's a great idea. Absolutely.
Yeah. And we are trying to increase delivery, and then we are still trying to identify partners. So in the last 2 days, we've identified 2 partners that can assist us in warm meal deliveries. So we're working on how to get them into our referral system so we can bring those warm meals right to them. In this case, we identified 2 critical needed delivery services, one which being kosher, one being vegetarian, and a willingness to help assist and expand those deliveries throughout the county.
Great, thank you. I'm glad you're pushing through and expanding the way we operate, and the collaboration with MCPS and the buses is, I mean, you can't get better than a win-win-win, rehiring people, using existing resources, and getting food to those in communities that need it. So good thinking. Again, thank you all for the incredible work that you continue to do. And as has been stated, we are here to support you. So thank you. Thank you, Mr. Chair.
Thank you, Councilmember Glass. So you know, it's interesting. I'm sort of a process geek, and so I've been fascinated by how we've set up the Food Security Task Force, implementing and taking into account all the incredible infrastructure that had been there before through the Food Security Council and the incredible local providers, including MANA and so many others that have been in this space for a long time. So it's been really interesting to observe from afar how that has evolved. And I am curious as to how it will evolve moving forward, because, you know, the task force has been created to meet the surge in demand that we see before us. But as we wrap up, and we have a 1:30 joint education and culture and HHS session, and all this discussion of food is, I don't know about you guys, making me hungry. But I just, as we wrap up, this is for anybody who would like to respond. Where do you see us going from here? I know that's a really broad question, but where do you think, we know where we need to go in terms of the hub model, in terms of needing to meet the unique needs of the different communities and address the growing surge moving forward. But either from a process standpoint or otherwise, what are your thoughts on where we think we need to go? And let's try to do this in 10 minutes or less. Whoever wants to speak to that. Mark, please.
Hi, Mark Hodge, DHHS. I'd like Diana Tato to talk about the hubs that are, have started to kind of organically pop up throughout the county, and they're generally food assistance hubs, but they're also bringing in other nonprofits and government agencies work in partnership in those communities. So Deanna has been a huge part of 40 some of these, including Gaithersburg and St. Camillus and some of the others, along with Luis Cardona from the Street Outreach Network, who's been working really hard with his team to get these set up and to provide delivery models. So I'd like Deanna to be able to speak to how that works and how I see that as the future of what we're doing in our communities.
Thank you, Mark. Hello, everybody. Thanks for inviting me. Yes, the work of the hubs is kind of a dream that I had for a long time. And that is because it brings together many organizations and expertises that were working independently, individually, and having these, for example, the faith-based organizations, a big church that has a big gym, that has a big kitchen, that has lots of space, that has tons of devoted volunteers that want to give to the community. Bring in a nonprofit food assistance provider that has the expertise of putting together these baskets of food, having the USDA Farmers to Families produce boxes, and then bring in, for example, social services, publications, communications, things about violence prevention, things communication about voting and school meals, and all of these things that have been working separately. Also, the SNAP outreach goes into that. And the part that these families that we're having that are suffering under incredible stress, with fear as well, and being able to serve them at their home, not just with food, but bringing the things that they need, such as diapers, soap, detergent, toothpaste, things like that, so that they can complete their quarantine in a safe way. That it's not, it's a public health good thing. It protects us all to keep those families into their homes, but it also helps them heal faster, heal better, and prevent so many ills in our community. Having this food available to them, it's more valuable than I think we realize. Food is, our essential need that is covered, that we are being able to provide. I cannot tell you how important it is for these families to receive these baskets of fresh vegetables and fruits. This is something that they don't get in the regular diet. So it is making them healthier, and it's really being a wonderful gift. I can share with you that I had a family telling me they were 3 months late in their rent, but they were so happy to have food at their table. The work of the hubs is amazing. It is a lot of work. It includes the participation of, as I said, faith-based organizations, nonprofits, and the food assistance providers. This is a model that is different for everybody, but I do appreciate the super support from the larger organizations such as MANA. And of course, I appreciate the support of the county council giving additional funding for these organizations. Also, for the smaller organizations who reach out to small niches of populations and who are also more flexible and can do so much more. Delivering food to homes is something that was never done before, I can say ever. But it makes a huge difference now. And it really, really helps families, not just that are COVID-19 positive, but those who don't have transportation, moms with a bunch of kids that cannot get to distribution sites. So we're making really a difference in a huge way. And I can only hope that this model of a hub of consolidation services and being and giving services in a more holistic way to our community, that it will continue and that it will get support, because support is needed for that. Thank you.
So I've had the opportunity to visit the Germantown Hub a couple of times. Got a tour from Gracie Rivera Oven, who just hurt herself trying to put food in a car on Monday night. So hope she's okay. But I know how hard everybody's working on that space and how, it has been incredible to see. And I know Councilmember Rice has been out there too. It's further unique because that hub is in the Black Rock Center for the Performing Arts. And so to have non-traditional locations step up and offer, their locations and services and volunteers and networks has really been beautiful to see. And I do think that is where I see us going, is how to sustain that moving forward. And I mentioned last time, and I don't think we're going to have time to get into it today, but the notion of community gardens, and having that be a huge opportunity, which people have been working on for a number of years, but now more than ever, people are focusing on solutions like that. But any closing comments from anybody on the panel regarding where you see us going? I think hubs is a perfect example. Are there any other things you guys want to highlight?
Yeah, I'll Councilman Rice, do you have something, or should I go? Okay. Yeah, so my name is Adam LaRose. I'm the Director of Advocacy and Public Policy for the Food Bank. Just want to kind of respond to the question, Council Member, on where we go from here. We have a unique perch throughout the Washington metropolitan region. We have the 2 largest counties in Maryland, we have DC, and we have 3 counties in Northern Virginia. And one of the things that we've seen in kind of the COVID era is the realities of what the supply chain presents to us, and it limits oftentimes what we can do and what we can respond to. And so what used to take 3, 4, 5, 6 days to order a truckload of, let's say, canned tuna, is now taking anywhere between 3 and 8 weeks. And so, I think we would like to see, as a food bank, the next kind of steps of conversations to operationalize this strategy, talk about how the food bank can play a role in, really leaning on our strength, which is, procuring a lot of food at very low costs and passing that savings on to the Manas of the world, the Nourish Nows, all the way down to the, soup kitchens and pantries that are in the communities that we've been discussing. So we'd like to see that. The mechanics of what that looks like are very important to us. And like I said, there's such a delay that I think the urgency is important to emphasize. And the last point I'll add, which we've touched on quite a bit and was in our statement with Mana, is that, we want to be very clear in emphasizing that we don't think that only food distribution can play a role in addressing the need that we're going to see over the next year or 2 years or 3 years. And that is why we've been pushing very hard for, and I know this isn't within the committee's jurisdiction, but, expansion of the earned income tax credit and the working families income supplement, and making sure that the investment in staff outreach as it relates to Montgomery County having the highest rate of non-utilization of SNAP throughout the state of Maryland is commensurate to what the need is and leveraging what the federal government can offer. So we're happy to play a role in all those conversations and kind of spell out what we can and cannot do within certain time frames moving forward.
Wonderful. Thank you, Adam. All right, well, let's go ahead and say thank you, everybody on the panel. Maggie, were you going to say something?
Yeah, I just wanted to quickly touch base to something that Adam had said about operationalizing part of this plan for the supply chain. We're in the process of those meetings at the moment. So I just want to make it clear that we have been working with our partners in Capital Area Food Bank, Mana, Clifton Baptist Church, Nourish Now, and a lot of other food assistance providers to come up and operationalize the plan for the bulk food purchase and to mitigate against future supply chain disruptions should we see a spike of disease and more disruptions in the fall.
Thank you. We'll let that go ahead and be the last word then. Thank you all so much for getting together. We will have, I'm sure, more discussions in the future, but appreciate everybody's time and keep up the really great work. We really need it. Thank you. And we'll adjourn now and be back in session at 1:30. Thanks a lot.
1:30. See you at 1:30. Thanks, guys.